We're going to be joined as well in the course of the meeting by Scott Towney and John O'Sullivan, who are attending for the operational performance item. But before we get into the main body of the meeting, I record apologies. Can I just take the opportunity just to say this is Lucy and Terry's last public board meeting, having served at least 2 terms. In Lucy's case, at least 2 terms. Terry 2 terms on the CCAM board, which is the maximum time allowed under our constitution. And they've both given outstanding service to the board and to CCAM. And so it is it's only fitting that in this public meeting I take the opportunity to pay tribute to what they have achieved. Both are going to be missed, and we've been eternally grateful for their commitment to patients and to our staff in the time that they've served on the board. The board's going to be honouring their service at our August meeting, but as this is our last meeting in public, it's entirely appropriate that I say our public thanks to them for their outstanding public service to the CCAM board, and they made a really good contribution to what we do, and will be missed by many, and we wish them well in their future endeavours. So thank you both. And if we were in a meeting room, we could lead a round of applause, and it's very difficult to do that virtually, but you have our applause in spirit, I assure you, via the medium of Teams. So in terms of apologies, I've notification that we have apologies from David Hammond, who's on annual leave, but Philip Astle is here Astel is here to speak for the finance function. Paul, I know, he's got to leave the meeting at 12:30, but then we should have the main business out of the way by then. So can we move on then to the minutes of the last meet? Oh, we've got apologies from Laurie as well, sorry, who is unavailable today. Minutes of the last meeting. Are you happy they're a true and accurate record? I'll take silence as a sense.
Sorry, David, it's Tom. Sorry, just 0521. That quote from me. TQ agreed and is encouraged to see collaboration of care between patients. I think that needs to be amended to see collaboration to improve patient care. I think that makes sense.
Yeah.
Please.
Thank you.
Thank you.
Thank you for clarifying. Peter, the action log.
Thanks, Chairman. So just one action from open action from the last meeting, as stated in the log, which is about related to ARP standards, and it links to the work of the performance cell, the business case of which I think the board agreed recently, and we've marked that for the September board meeting to bring back a formal update.
Thank you. Any questions on the action log, colleagues? Clear? Okay, thank you. We can now move on to the by report just to introduce the main body of the meeting. And just to really make the point, the main purpose of today's meeting is unashamedly to seek assurance on the measures we're taking to provide a safer service as is reasonably possible, given the current demands on not just our service, but also the wider NHS as well. And for that reason, I've reluctantly agreed that the strategic update is not on this agenda, so we can focus it's really appropriate we focus our time on what is currently a challenging situation, which are all of our clinical teams and emergency centres are striving to give the best service they can to the patients we serve. And it's important we acknowledge the importance of allocating resources to ensure ongoing safety. So the primary assurance today relates to the immediate steps that are being taken. However, as a board, we must also seek assurance that the executive is allocating sufficient resources to ensure longer term strategic solutions as well to deal with our current challenges. The board's already discussed this matter at our development session in June when we explored some of these solutions, and it's important that we have this conversation as our public meeting today. Such as the critical path we set for the Better by Design programme, development of our performance cell, which has already been subject to a business case and been approved by the Finance Committee, and also for supporting our workforce. So whilst the Quality Patient Safety Committee will continue to assure the aspects of our patient safety going forward. We've also revamped one of our primary committees in the trust, and we'll now form an operational performance committee, so we can now separate the discussions at board committee level between finance and operations, so we can appropriately focus in detail on operational matters, but also at other meetings concentrate and give our finance position appropriate assurance and scrutiny as well. So we think it's important we make those changes at this time. In the Chief Executive report, Phil is going to set out the challenges and we'll take you through how we're working with our partners to manage the current demand on health services and deal with the ongoing challenges of COVID, which are still significant and are still affecting our performance in a number of ways. We'll also hear about some additional funding which has been made available for ambulance services, which again is an important milestone, I think, and recognition of the challenges that ambulance services across the United Kingdom are currently in. But this money has been made available for those within England. But I think it's appropriate before we start the meeting that from the chair, but on behalf of the whole board, that I really pay tribute to all of our staff in the organisation, particularly those working in 111, EOC, our ambulance crews, and particularly our volunteers who have really stepped up to help meet demand currently, who in the face of adversity are showing renewed vigour and doing a superb job in trying to meet the demands of the public. We've all heard, we are aware of the pressures, but I'm also very touched by the stories I continue to hear from members of the public about the compassion and kindness shown by our staff towards the public in difficult situations, often when they've experienced a long wait. So I do pay tribute on behalf of the board to all of our staff, and any discussions we have today are in light of, we know our staff are doing a good job. We want to support them going forward and make sure we support them appropriately, but also make sure our patients are getting the best possible care they can in these very challenging circumstances. So that's to hopefully set the scene for the meeting. It's important, as all meetings of the board are important, but we do need to make sure we assure ourselves that the actions being taken to keep our patients and our staff safe. So let's move on now to the board assurance framework. Peter, please.
Thank you, Chairman. So I'll be brief today just on the BAF risk report. It's the usual format the board's now very familiar with. Excuse me. Section 3 illustrates the extent to which there is oversight of the risks through the board, either directly through these meetings or via one of its committees. As you mentioned, Chairman, on today's agenda, there's specific focus on the BAF risk related to operational performance. This is a multifactorial risk and incorporates the impacts of both operational performance, as we'll hear about later, and quality and safety. And as stated in the report, following challenge from various areas actually, but most recently the Audit and Risk Committee, over the next few weeks through the Executive Management Board, we'll be reviewing these risks to ensure there is robust contingency planning included in the actions. That was one of the gaps that the Audit Committee identified, as I say, at its last meeting. Other than that, Chairman, that's all I was going to say by way of introduction. I'm happy to take any questions.
Thank you. I mean, we may revisit this at the end of the meeting because we may wish to look at some of the categories again in light of our discussion. But currently, can I just take questions and also assurance from the board that as we see it, that we've covered the main risks in the assurance framework. So first of all, I think Lucy, you have a question?
So looking at this, given 2 risks have a likelihood of 5, and one of those is around our demand management, which is basically saying we think this is going to happen. And the context of the waits that we're currently seeing around C2, but particularly C3, 6, 7 hours, I really think we need to consider a risk in the delivering quality quadrant, because if we're not able to deliver to our plan, that is going to have an impact on our patient experience and patient outcomes, which I know is sort of in that risk, but I think it deserves a separate risk to be looked at by the quality and owned by the Quality Committee.
Okay, thank you. Colleagues, I think we contend with that comment. I think it's important we really highlight these matters and show that we are, as a board, are truly focused on the matters, and we are doing our very best to manage all of the risks. So we can amend the BAF in that way. We say we may wish to revisit it at the end of the discussion as well. in the end of the meeting today in the light of what we're going to hear. Discuss.
Yeah, I think just to say, I think that's a really good suggestion. And as I said in my sort of introduction, I think that the risk, covers both, but I think it's a good idea to separate them, and maybe we can just link them in the risk register, just so that there's a clear line between the two, because one obviously impacts the other, as Lucy alludes to.
Yep. Okay, thank you, Peter. Very helpful. So with that, we'll move on to an important matter. Beth is going to present a report on infection prevention and control.
Thanks, Chair. So this is the second time as a board since the start of the global COVID-19 pandemic that we have brought a specific board assurance framework in relation to infection prevention and control here. This is a national document from NHS England and Improvement, and the CQC do insist on having a copy of this as well for their assurance, just so there's transparency about where the document goes. We do send it to both NHSE and to the Care Quality Commission once it's been approved by this board. It's here to give us a framework for assurance of all things IPC related. And there are some additions to this version centrally, which are highlighted in yellow in the report. So you can see what's different from the last version that we took at the Trust Board just over a year ago. So what I'm really pleased to say, however, is that we have no significant gaps in assurance. The only work that we are not fully compliant with is the development of a policy, which is a national policy being done via ACE, the Association of Ambulance Chief Executives. So that's work that we're all doing, but that is the only thing that is outstanding for us and is something that is in train. So I can give really good assurance around our systems and processes and our actions in relation to IPC generally and specifically to COVID-19. What I can't give you through this, and it would be wrong to, is compliance against all of these things. That's a different matter and something that needs to be, that clearly we're looking at and we'll scrutinise through the Quality Committee. But I can't sit here and say we're fully compliant against all of them on any individual staff member. This is more around the organisational systems and processes rather than compliance against it. And I think it's important to note that our staff rightly are struggling wearing PPE day in, day out. It is incredibly difficult. And it's also incredibly hard for managers to continually give that message and to continually police this and make sure that we're doing everything we can to keep staff and patients safe. So it's something that absolutely is still really important. Really important that staff continue to do it, but we do acknowledge that there is some PPE fatigue, and we're having discussions about how to help that situation and how we can support staff. So I just think during this item it was important to note that. I can't give you assurance about that because that's not what it's about, but just to note that we are doing further work on our compliance against it as well.
Thank you. Colleagues, any questions or comments on the report? Subo? Then Lucy.
Chair, just a quick question, Bethan. Do I take it there aren't any problems with the supply of PPE now? We just have, it's just a compliance and support of staff, but there's no. That's problem.
Right, correct. We have good stock levels in all areas of PPE, so I'm pleased to say that's a very differing picture to the issues right at the beginning of the pandemic. But yeah, we have no current concerns.
Great, thanks.
Thank you, Lucy.
And mine was just related to particularly the personal protective equipment for staff in terms of fit testing and the powered hoods. I noticed in the IPR the fit testing was coming up as red and 65%. That might well be because of the powered hoods and therefore it's not really red, but I just wanted to check where we were on that because obviously it's been an extremely big issue for us through the COVID crisis.
Yeah, absolutely. Emma, do you want to, you're probably closer to this. I see your hands up anyway. Do you want to take that?
Yes, of course. Thank you. Lucy, you're completely correct. So all of our staff who are patient facing have access to powered hoods, including our student paramedics. We're doing a specific piece of work to understand who still requires fit testing going forwards, because the powered hood is usable in pretty much 99% of situations. There's a task and finish group working at it, but we will work with the IPR to make sure the metric is quantified in terms of the denominator of who still needs fit testing. So the heart teams, for example, do, because they also they use different equipment in different locations, but it's a much smaller scale issue than it has been historically because of the powered hood solution.
And are our staff generally therefore wearing the powered hoods?
They're all wearing powered hoods.
Okay.
Yeah, absolutely, and successfully, and people are getting very used to them and reporting good use. It's a good piece of kit that they have.
Okay, good. Thank you.
Thank you, Howard. Then Tom. Howard.
Yeah, sorry, my question was very similar to Lucy's, so thank you for that. Just a supplementary, was in the news, there's been sort of recently comment about the ineffectiveness of some of the previous face masks. Does that affect us in any way, or is that?
Yeah, I've seen that headline this morning as well, Howard. It was particularly in relation to nurses, wasn't it, in acute COVID positive wards around FFP2 and 3 masks. So I haven't. It came out this morning. I haven't read the full article. We have no reason at the moment to be concerned about anything that we used in the past, and clearly our powered hoods are fully compliant. But we'll be looking at, as we always do when anything like this comes out, we'll just be making sure that everything we used was appropriate. But it goes through rigorous checking, and our IPC team personally check every order that comes in on every pallet of PPE. So I can't give you absolute assurance till I've read the article in full, but I can assure you that we will check. Yeah. So just thank you. Just by observation, then the powered hood decision, in retrospect, was a very good decision, in spite of some of the difficulties arriving at it. But it does seem that was a good decision.
Yes, I think it was, and I think the safety of our staff is paramount, and I think grateful for the teams that have implemented that solution so speedily. Tom.
Thanks, David. So Bethan, two things. One is because I may have misheard you. I think you said at the beginning that this use of this framework is mandatory and that CQC asked to see it. But in your cover note, you say using this framework is not compulsory. No, I didn't. Yeah, it's not. NHS England request a copy of it. Right. If I said mandatory, that was an incorrect use of mandatory. We are requested to complete it, and it is good practice to complete it and assure our boards. Yeah, thank you. And I agree, it's good practice. The second thing is it is a very generic framework for all healthcare settings. And so do we have a timescale for the ACE work on an ambulance specific set of control hierarchy that we can then take through QPS and because it's very specific to our setting? Yeah. So the IPC group within ACE are working on it. It will come through to QGuard and to NASMED. So that's I use too many acronyms. That's the Directors of Nursing group and the Medical Directors group within ACE. But I don't know a timescale off the top of my head, Tom, but I can check with our IPC lead and let you know. And we can bring it into the cycle of business for QPS. Great, thank you very much. Thanks.
Thank you. It's a question from Chris Gond. Hi, Chris.
Hi, good morning. It's a very quick one. I'm into Emma or to Bethan. We know that at King's, one of the issues, particularly with PPE, it was fit testing, and that has been an issue, particular from BME community, that they had to design very specific ones that fitted BME people working in the front line. Now, is that something that we are doing for our staff here, particularly those who are on front line?
So for us, we have a range of kit of a huge number. I think at one point, Emma, we had 22 different devices available. So absolutely, it doesn't. So it's not so much around BME; it's around everyone personally. For example, we had a big issue around beards. So staff members with beards and needing and facial hair and things like that. Even if they were compliant from a facial hair perspective, still needing different fittings. So we have a huge range. And then obviously the powered hoods negate the need for all of that as well. So many options for individuals.
Okay, thank you. I think can we conclude on that matter? Can I just sum up? I think I don't think there's any more questions I can see on the screen. Just to sum up, we received the report and do note and take assurance for the work that is being done in the organisation. And can I Bethan, through you, not only thank yourself and your Deputy Judith for your leadership on these matters, but also in saying thank our procurement function, control infection team, and really just acknowledge the point you made, the frontline staff and the pressure they must be already under pressure, but to work in excessive heat as it was last week and wear a full set of PPE to keep them, or to keep our patients safe, but also our staff safe, I think is to their credit. So I think it's some really good organisational work's gone into this important subject, and regrettably we're going to need to keep the focus, aren't we, for some time yet, because of the recurring issues with COVID, which have still not gone away in society. So we really do need to keep absolute focus. So thank you for what you're doing there. Can we move on to the next item, which is the the Chief Executive's report? Philip.
Thank you, Chair. I'm going to start by just shaping the rest of our session today, because normally at this stage I would talk quite a lot about operations, particularly given what's going on in operations at the moment. But we've got an hour and a half in the next item for operations, so I'm not going to go large on it in my Chief Executive's report. I'll leave, because I'm going to lead that next session. But I do want to just state that everybody uses unprecedented a little too much, but I don't hesitate to use unprecedented as to the situation that's facing the ambulance service at the moment. It's not just CCAM that's facing this. In the past, individual trusts have got themselves or have been placed into difficulties by things like the spread of the disease, by some other issues, and that's not uncommon. This is the first time that the entire ambulance service has been in such a troubled and demanding situation. That is, even though it's not all over the press, it is recognised at every level. And so, for example, 3 times a week, all the ambulance chief execs are meeting with the heads of urgent and emergency care from the NHS, working on what can be done by the centre to help the ambulance service in this particular time. And the options are quite limited, as you can imagine, but they are being all options are being considered, and you'll remember that at one stage we had some armed forces support. There is discussions going on with the military at the moment about providing armed forces support across all 10 ambulance services. So this is it's a big issue, and it's very widespread. And of course, mutual aid, which is what we would normally be asking for when we get ourselves into this sort of place, is not available because everybody else is in the same situation. So we are in REAP 4 and have been for a while. We are in a BCI, and we will probably be in both for a while to come. We are spending most of our days in an advanced surge level. So today and yesterday it's a bit better, but up until now we've been spending well over half of each day in SMP4, which is the highest level of surge management. So that's the situation. We'll talk about it in great detail under the next item. There are a couple of things I do want to pick up that were in my reports, and I'll just update on them. So firstly, the item on self-isolation, there's a big public story, isn't there, about the fact that NHS have got an exemption from the self-isolation rules. It isn't quite as clear as it sounds in the press. There are rules around who can be exempt the self-isolation rules, and those rules affect the ability for it to be applied. So we have allowed and put in place a system whereby those people in EOC and 111 can take advantage of that exemption. The problem is that most of our the number of people who are self-isolating from the EOC and 111 don't fit the rules, and it's mostly about the fact that they've got someone in their own household who is the reason why they've been pinged. And so it has a really, it's great that it's there, but it's a really small advantage. The difficulty with field ops is that you can only apply the exemption if you're not going to come into contact with vulnerable patients. And of course, we don't know who we're going to come into contact, so it's a really difficult thing. We're still working on it to see if there is a way of applying it, and we have national guidance that might help. But at the moment, we haven't applied it to field ops for that reason.
A question from a governor regarding sort of difference in approach with police, fire, and the border services compared to ambulance services. Could you deal with that point, please, as well?
Yeah. So the question is answered by the fact that we do have the exemption, and in exactly the same way. It's just more difficult to apply for us.
Right. Okay. Thank you for clarifying.
The second one is I talked in my report about some additional funding that has been again publicised. This is part of the centre's reaction to the trouble that the ambulance service are having. So £55 million of money have been made available across the ambulance services. Some of it is being kept centrally for national projects, but each of the trusts has been given a slice of that. And we have there are strict rules about what it can be spent on. It's to cover quarters 3 and quarters 4, and we have put in a plan which is going to be approved any day by the end of this week, is what I'm told, and that will allow us to upgrade the number of call handlers that we've got. So that we can fix the problem with call answering with the additional demand, increase the clinical support in the EOC so that we can get better patient safety, provide more HALO support, and HALOs are the hospital ambulance liaison officers. So that's to minimise the hospital handover delays. And we are seeking some of that money to be spent on additional private providers. The difficulty is the private providers are having exactly the same problems as we are, and their staff absence is a problem in the same way as us. So we don't think we'll be able to spend much money on that because there isn't the availability. But we will keep supporting it. But anyway, that's the plan. The detail not to be made public until after it's been agreed.
You use 2 acronyms. Forgive me interrupting, but just so we're clear, in case we have members of the public listening, you refer to REAP and BCI. Just so we just clarify that, please.
Right. Yeah, so REAP is our action plan level. So it's a measure of how busy we are, and it gives us a whole bunch of actions that are allowed that we wouldn't normally take. And there are 4 levels: 1, 2, 3, and 4. We're in REAP 4, which is the highest level of REAP, as are the other ambulance services, with the exception of 1. And BCI is a business continuity incident. People talk about major incidents or serious incidents. A business continuity incident is the one where you use it when it's going to be a sort of long-lasting effect on the business, and that again gives you some ability to not comply with some policies and to use your workforce differently.
Okay, thank you, Matt. Thank you.
there are a couple, the other thing I did want to note, it's all a bit doom and gloom so far, but I did want to note Fiona's Queen's Ambulance Medal and congratulate Fiona. So this is a second visit to the palace and well deserved. But it's not such a reflection, particularly on Fiona, but on it's a real nod to the trust and to Fiona's department, particularly that she leads so well. So well done to Fiona.
Yeah, congratulations to the both, Fiona. They've thoroughly well deserved for what you've contributed to the CCAMP, but also to ambulance services nationally. So thank you.
And so we're going to move on and talk about operations in a second. But before we did that, there's been quite a lot of questions from folk about our use of the press. And I just thought I'd show you some of the innovative things that we have been doing and continue to do to try and get the message out to the public. So these are locally and nationally seen, and I'm going to show you a few clips in a second. But we are controlled to a degree by the national lines to take, but locally we have and continue to do our own thing. And a lot of you will have seen James Pavey, who's been starring on the small screen, but we're getting our staff to be the front, and we find that a very effective way of getting messages out. So if Adam could take over the screen and show 2 minutes of clips.
Thanks, Philip. Soundtrack issue,
and then we're not getting any noise.
Apologies all, let's run that again.
We are hoping that the England team will bring it home to us this weekend. Please remember my team are out there working hard to support you all.
We're expecting to be very busy this weekend with the football and with the increased volume of people out and about. So before you call 999, can you consider might be other options that are more suitable?
Before you make that call, ask yourself, is it an emergency? Can I go to the local minor injuries unit? Can I call out of hours GP? Can I wait until my own GP opens?
And I'll be working this weekend, and we really need you to help us by considering other options first. Is your call really an emergency? And remember, it's coming home.
dial 999, you'll be asked a series of questions to determine the most appropriate level of response for you. This may be an ambulance, or it could be a GP or an out-of-hours referral. You may even get to speak to a clinician like myself, or be asked to make your own way to the A&E.
If we attend to you and take you into hospital, unless your condition is life-threatening, you will not be seen any quicker than if you was a walk-in patient. You would be triaged exactly the same. So going in by ambulance doesn't mean that you will jump the queue.
Thank you, Philip.
Thank you very much. Those campaigns will continue throughout this period, and will be adjusted. We're getting some of our highest hit rates for those staff clips than we do anything else. Obviously, the biggest impact would come from a national story in red top newspapers, but we're not in that place. So I'll hand over for questions.
Can we just thank all the staff who contributed to that? I thank obviously colleagues in communications for putting those together. But also, sadly, football didn't come home, but our staff remained resilient in spite of that. So we thank them for their efforts. We really do. So Philip, over to you.
I was saying, Chairman, I'll hand over for questions now before we go on to the ops session.
Thank you.
So, Chris?
Any questions on the report?
Thanks very much, Philip, for your report. I mean, that was really, really good. And I know you did talk a lot about gloom and doom. Now, if you look at the list of glooms and dooms that you've just given us, which one really gives you a nightmare?
It's the time we're taking to get to patients. That's why we're throwing so much at the EOC, because that's the only way we can reassure ourselves that those people who are waiting, the 7 hours that Lucy was talking about earlier, are the right patients and not the ones that are going to be suffer serious harm because they wait.
And that clinical assurance will be picked up in the presentation we're about to have. So I think it's important. It's a really important subject you raised. So thank you for that. Any other questions on the Chief Executive's report?
Tom.
Great, thanks. Thanks, Philip, for that report. And I think the fact Amanda Pritchard's bulletin yesterday started with pressures on the ambulance service and asked everybody to try and work together to solve this is unprecedented. It is an indication of just how hard things are. So I really appreciate what everyone's doing. In your written report, item 5, you talk about EMB overseeing an agreed approach to improving staff experience. I'm just wondering, is there a sort of a short summary of that you could give us? Because I think we all recognise how hard this is out there.
Yeah, so we've just been looking at a series of measures, and it gets more difficult as we go up through the REAP, and it was largely not overtaken by REAP. But so, for example, a classic would be a meal break. So our policy tries to give staff the best experience by saying that we will try and return staff to their home station for their meal breaks. But in periods where we're in surge, like we are, staff are getting separated from their base station by further and further distances. And so actually it adds to the problem if you return staff to their home station if they're 50 miles away, and therefore to make sure that everybody gets a meal break, you have to change that. And so it's it's the emergency measures like that we're considering. There isn't it isn't the time we've considered for knickknacks and that sort of stuff. It's more about getting people the basic rest and making sure that they're covered with that. Thanks for that.
Thank you very much.
Howard.
It's a difficult one, but to what extent do you think what we're seeing is a result of the success of 111 first and basically a transfer of workload from primary care to us as a result of that? Is there evidence of that, and therefore is primary care seeing a commensurate sort of slight reduction in what they would expect to see in these circumstances?
When you look at the numbers, primary care appear to be getting a normal and servicing a normal workload, but there is no doubt that 111. I think what has happened is that the workload should be bigger, and a proportion of it has gone into 111 rather than to primary care. It's not that primary care aren't working hard or seeing patients; they're seeing patients. I just think that the extra demand is falling largely on 111 because it's there, and you don't have to get.
It was promoted, yeah.
Yeah.
So we're a victim of our own sort of success.
There is an element of that, and Scott, John will be talking about that in the next presentation.
I think in the interest of balance, though, the Royal College of General Practice were featured on national news this morning because talking of a crisis in primary care. So I think there appears to be an arms race at the moment. So who's got the greatest crisis? The key thing is that we've really got to make sure we test as a board. We're doing all we can to work collaboratively with everybody in the system, both the NHS, but also the voluntary sector and others, as Philip's talked about, to make sure we're maximising our resources as best we can, because it's a challenge. Also, Tom, you made reference to Amanda Pritchard. So I think we should also just refer in the minutes to congratulate Amanda Pritchard on her appointment as Chief Executive of the NHS. So that was announced yesterday afternoon. So we look forward to welcoming Amanda on a visit to CCAM in due course. So I've asked the Chief Executive to issue the invite. So we look forward to seeing her whenever her diary allows. So can we move on to, there's no other questions. Can we move on? Sorry, I missed that. I do apologize. Michael and first of all.
Philip, can I just ask? I thought what your colleagues are doing in terms of trying to get the message out to the public is really impressive. But if, and this may come up later, if our resources are limited, and what you're saying is the ability to increase that level of resource is really constrained in the short to medium term. The only way you deal with this is you manage demand, which you're trying to do. I just wondered, these public awareness campaign is very good, but are we actually tracking what impact this is having? So I don't know when they went out, but I would be beginning to see some change in demand if they're beginning to have some impact. And I wondered if I know our resources are limited, because I think this must be one of the way forward, and we may need to get even more sophisticated in our messaging and our public awareness campaign. This is incredibly sophisticated. I just wondered, have we thought that through, going forward, and what feedback loop have we got?
Yeah, and it is. You're right. It's incredibly difficult to tell whether they have any effect at all. Because you never know that someone has made their own way to hospital because they saw an advert. The only thing you can tell is how many people are looking at the advert, and we know that the sort of clips that we've just shown get so many more views than the traditional press statements and that sort of stuff. But it's about trying everything. But how do you if we do a week's worth of a campaign, such as we did for the football, it's really difficult to tell whether or not that's had even something as specific as that. We know that the weekend wasn't as bad as we had predicted, but we don't know how much of that was down to the media's effect.
Do you want me to come in quickly here, Philip?
Please, Janine, then I'll take a question from Paul.
Okay, so really good question, Michael, and one that vexes us. As Philip said, all we can accurately measure is how many people have seen it. And what we've learned through analysis over the past 2 or 3 months is actually national messaging that we've been sharing has been having decreasing impact. So that's why we've switched tacks a bit and worked with our staff to have them front up some of the messages, because that has far more impact. There isn't any significant national data around the impact of any of this. There was some historic data from London Ambulance Service about 8 years ago, who invested a lot of money in a big campaign. The Not a Taxi campaign, it featured pictures of a taxi next to an ambulance. Actually, that increased their 999 call volume, Michael, rather than decreased it. That's the only sort of particularly relevant research I know, but it's a question that we're talking about nationally. But as Philip said earlier, actually, we're all doing our bits locally with what we can. What we really need around this is a concerted national campaign, because I think that's the only thing that's really going to significantly have an impact.
And my view, sorry, Chair, and my view is that must be the way forward. And I think that's something, as a trust, like all the other trusts, we need to be escalating up the system, because I can't see any other way of dealing with this.
Yeah, I think we have, and I think in fairness to the Chief Executive and the other Chief Executive Ambulance Services, they have been escalating. And I think there is, let's say, difference of professional view of the impact, and it goes back to Janine's points. I think the more you publicise it, something there is a view this increases demand. But nevertheless, we have an accountability of this board for the quality of our services, and I really think as a board there does come a point where we would have to make it absolutely clear, for the sake of the safety of patients and our staff, that we are we're at a particular point of demand we can't sustain. So I think you raise a fair point. We need to, and I certainly will make comments with my colleague chairs nationally as well in this, to make sure the ambulance sector's voice is heard in dealing with what is a national emergency. So thank you for that, Michael.
Without wanting to prolong it, David, sorry, just a point I think is really important here is absolutely, Michael, this is about trying to influence public behaviours and manage expectation. A key driver for us has been about supporting our staff. Yes. And what we have seen is really positive feedback from Emma's teams and others, that actually they feel we are trying to support them, almost regardless of the impact it has. So I'm not saying that's the only reason for doing it, but it's an important reason.
Thank you.
Thank you, James. Really important point you made there, and also why we've devoted most of this board meeting to the current pressures, to make sure our staff do understand this has got everybody's attention. Tom, sorry, can I go to Paul first, then back to Tom?
Yeah, thank you for your report, Philip, and thanks for everything that everybody's doing to respond to this very difficult situation. It's great that you're meeting, all the CEOs are meeting on a very regular basis. I wondered if we're going to expect any support nationally, and I wondered what impact and what was top of their agendas, in terms of asking for help nationally, really, Philip.
So there are a number of items that we're discussing. Firstly, I talked about the MAC-A request, the military aid to civil authority. That's one of the outcomes of those meetings. Hospital handover delays. They're working they've applied a lot more resource to try and fix those problems. If I'm honest, that's going to be mostly effective in other trusts, because the very long delays are in the Midlands and the North. But some of our hospitals are on the list, so that's good. The media handling is another one that Michael was just talking about, that's working some ways, and then the rest of them are the making sure that the resources that we've asked for to spend the additional money on are freed up for us, and the money's not held up by red tape, etc. So those are the sorts of things that
very
we're
important. Yeah, thank you.
Yeah, thank you. Tom, your hand was up.
Yeah, it was just a query really to Janine. So the national group working on this, are you in touch with SPIBE, who do the behavioural science work around the pandemic, look at public behaviours that might be able to provide some useful insights to inform any campaign to try and manage this nationally?
We're not quite there at that stage yet, Tom. Our initial challenge is actually getting acceptance and recognition at a national level from NHSEI around the need to do this. So as Philip mentioned, we remain in level 3 of a pandemic. That means there are restrictions on our ability to talk directly to the media. We don't have a free rein in quite the way. We have seen a little bit of change in the last couple of weeks, but absolutely the sort of behavioural and psychological drivers behind this would be key. But I'd be misleading, Tom, if I said we're at that stage yet. It's just something that is gaining a little bit of momentum, but we're a way off.
Yeah, and we have to recognise there is national control over this, because we are dealing with a international pandemic, and certain controls are coming into place which we wouldn't normally have. So to acknowledge that. If I can now move on, please, to the main item today, which is the operational performance. We're going to have a series of presentations. Philip, do you want to introduce this item, and then which of our colleagues then are going to be presenting? And then we'll have time for questions and discussion.
Yes, I will. And Peter, are you inviting Scott and?
Yeah, John Scott should be here.
Okay.
See Scott's there for sure.
Yep, I can see them now. I can see them. Good. So welcome everybody to this. This is the mainstay of today's board, and we're going to do about an hour of talking, and then we'll have half an hour for questions. So if we can keep questions till the end, that would be good, and run it. The structure of the presentation is we're going to set out firstly the high-level situation in each area. The risks to patients and staff, but we're going to concentrate mostly on what we're doing about it. I'm not going to describe the national situation. I think we've just done that in the conversation that we had. So that piece I'll take as read. But just to drill down onto the causes, the demand has been higher than it should be. Particularly the number of calls coming in is high. In 111, it's significantly higher than it would normally be, and the detail behind that will be made clear. But it's almost the bigger problem is the level of staff abstraction. So we were up to 250 staff off with COVID last week. It's down a bit this week, and that is good, but it's still in the just about 200. And we've also seen other sickness going up. So even though we're not doing as much training as we had, our staff abstraction at times is higher than it would be if we were doing training. There's in the sickness, there's a significant element of mental fatigue type sickness, so that's something that we've been predicting for a while, but it still doesn't make it any easier to deal with. So that's the nub of the problem. The presentation will show you the actions we're taking to keep the public safe despite the performance issues that we're talking about, as well as what we're doing to improve that performance in the short term. you'll be aware of the additional funding. What that will do is it will help us because we can't buy paramedics, so we can't get additional crews unless we start doing things like splitting crews and using military people to drive the truck. That will give us a small increase, and we'll get a small increase from I think that from maybe a reinforcement of St John's from a national pool, which is held by the National Ambulance Control Centre. At the moment, we use St John volunteers in small numbers. We are looking to see that increase, but it'll be a national apportionment depending on demand. So that's the only way we're going to get more staff. So the rest of it is about how we use staff, what we have got better, but also how we make sure that the patients that are suffering the long waits are kept safe. And we will be using a significant amount of the additional money to reinforce the EOCs over the next 6 months to increase the safety of the patients in the queues. So today, we're going to focus on the work to manage in the short term, but we shouldn't forget that, as David said earlier, we are also doing the strategic work required to fix these issues in the long term. There will be national work as well, which is not yet in any way defined, but there is a national recognition that the ambulance service as a whole needs more support from the centre, so that the service never gets into this situation again. So that's at the strategic end, and of course the work that we're doing at the strategic end are things that that David mentioned briefly, things like the performance cell, the ability to apply our staff to demand much more dynamically and much more effectively, and the whole Better by Design program, which will again work to make sure that what we have got is used in the way that it should be, but also taking more of the demand off the road. By the other way of demand management, it's not just about stopping people calling, it's about doing more hear and treat. So you'll see some numbers in the presentation which give us an idea of how that's going already, because of the additional the measures that we've been taking, and things like the Cat 3 and 4 pilot. So it's stopping people calling. It's then doing an awful lot of hear and treat. We're then going to work on for those who do need to go to hospital and can't make it, can they go in a taxi? And then you do as much see and treat as you can, because that's quicker and better for patients. And so we're trying to minimise the number of people that we get down to having a journey to hospital. And all of those strategic programmes we'll be looking at that. But today we're going to concentrate on the here and now. So I'm going to hand over to Emma, who will talk through the headline plan, and then she'll bring in John and Scott to talk about the two services. Just so that and we'll be doing another version of this next week with the CQC when we're having a session with them as part of our normal engagement with them. So Emma, would you like to take over?
Thank you very much, Philip. Thank you, Chair. We have, myself, John and Scott have created a couple of slide sets that hopefully, I believe, Lee or one of the team will be driving.
Yeah, Peter Lee did send a PDF through. Well.
Yes.
You should have that on your email.
Yes, absolutely. Thank you.
No, I think Lee's just going to show the slides in a second. Stand by.
That's absolutely fine. Thank you. So the plan is that we are going to talk very much a brief overview, picking up from Philip, but focusing initially on frontline ops and the programme of the performance improvement plan. I'll then hand over to Scott, who will cover the emergency operations centre, and then John will follow up with 111. Thank you, Lee. If you'd like to just dip through to the third slide, please, which is the start of the content. Thank you. Philip's given a really comprehensive summary of some of the challenges that we're facing, and I think the important thing that I wanted to raise here was acknowledgement that there are multiple factors that are all contributing now to the position we find ourselves in. We know that due to the non-achievement of our ARP standards, that there may well be harm that is resulting from those, particularly those very extended waits for response from us. We know that the acuity and complexity of patient need is going up, and I'll give you some more information about that shortly, both within the physical conditions that patients are suffering, but also with other complexities, including mental health and even some of the social care issues that people in the environments they're living in. We're doing a lot of work on increased job cycle time, but due to some of the hospital handover delays, some of those benefits that we're seeing aren't being materialised in terms of tangible additional resource capacity to support the delivery of those ARP standards. Again, and I'm sure many of you are aware, it's been in the press recently as well in other ambulance services, but hospital handover delays, some of them which are extremely long, very significantly beyond the 15-minute target. Again, there are circumstances where those extended delays may have caused harm. Philip's mentioned abstraction. Absolutely right, and some of the rota mismatch. This is very much around the rotas that we have based on activity from a number of years ago when the modelling was done, and this is where the performance cell will help us go forward. All of this together has resulted in us being, as Philip has spoken, at REAP level 4 and in a business continuity incident. Now, what does this physically mean? The REAP plan is a national ambulance plan. It provides us with a list of very specific actions that we escalate through, everything from moving all clinicians from the front line who can undertake frontline duties to frontline duties, cancelling training, reaching out to other partners to try and ramp up response. It's very much an escalation plan that allows us to change the way that we deliver the service and function as a trust. The business continuity incident also then allows us to work outside a number of our protocols and policies under the guidance and authority of our strategic commanders. And again, it allows us to engage with our local systems in a really proactive way. And a positive thing about that has been we now have calls every weekend with the 3 systems together to talk through some of the challenges that we're experiencing, which is a really positive piece. It's something where we've taken the proactive stance because usually the calls are very much a Surrey, Sussex, Kent, Frimley, but this is an opportunity for us to bring everyone together. Next slide, please, Lee. So just briefly, activity and acuity. We are our number of incidents. We are back to a level that we saw at the beginning of 2020. You can obviously see the fluctuation. The recent decrease in incidents has been mainly due to the fact of the number that we can physically get to. But it's recognising that the proportion of C1 and C2 calls has gone up, as you can see, bottom right hand side. And this is something that Acute Trust are reporting as well. The primary reason that's being given across the system is the fact that less people who have got chronic conditions have been able to access the ongoing care that they would have done had we not been in a pandemic situation, because everything has had to be a bit more distant. So those who've got chronic conditions historically are now beginning to present with worsening presentations to us. So we are seeing that higher acuity of call. Next slide, please, Lee. So when we talk about the resource provision, what is the impact here? So again, some pictures and graphs on the right hand side. The bottom one is our abstraction rate for operations as a whole. The top line is the one to look at with the The dotted line just below it is the targeted level at about 28-29%, and you can see that actually for quite a lot of the time in the last couple of months we have been significantly above it. It's worth noting the reason it drops down to the right hand side of the graph is that's looking forwards, and we put sickness in on a weekly level basis, and because obviously that would fluctuate, so it's accurate as a retrospective review. But you can see for June and into July we were running at 30 to 35% abstraction, which is significantly higher than we are A, funded for, but B, really it creates real difficulties at managing those resource hours. We need to just kind of pick up on a couple of things around this. We've done a number of actions to really try and mitigate some of this abstraction. So the training level in here is very low. The training that's present is what we're calling essential training. So it links to students at university who are part of the pipeline recruitment, where we need to keep that training going in order to support them coming out into ops and going live. We know that, and it's been mentioned about the self-isolation, and the national HR guidelines have not actually resulted in any of our staff coming back. We are offering incentivised overtime, and that has always been a positive thing in the past, but it's not resulting in the same number of hours we've seen previously, primarily because people are fatigued. And in combination with that, we've got maximum annual leave being taken because it's summer and people are now being allowed to travel, and people quite rightly from a welfare point of view are wanting some time off to spend just sort of resting, recuperating with families. I think the other thing to note around the annual leave, of course, is that this year we have a higher level of annual leave within the system because we've all been allowed to carry over additional annual leave from last year that was unspent. So that does result in a higher level of annual leave that needs to be taken anyway. We have considered buying back annual leave to see whether that would provide some additional support. But actually, from a staff welfare point of view, it's really important that staff are allowed to take the annual leave that they are rightly given. So we haven't done that. But it is something that means that annual leave we're going to need to be managing very carefully through the year. But it's having a big impact at the moment. We've reached out to private ambulance providers, really not able to get more. Philip's picked that up, and the piece around additional support from other locations, working with fire service, and obviously the MACA request that Philip spoke about as well. Next slide, please. So this is just a really brief overview. I've talked briefly about overtime, but it gives a graphical representation that shows that in February, March, where we had the same incentive program in, we were consistently getting 12 to 1400 hours from overtime. Currently, it's fluctuating at around 800, sometimes slightly higher, but often a bit lower than that. So it's the same incentive, it's the same people, but obviously it is a less attractive position for people to be in at the moment. In terms of job cycle, I think this is quite interesting. If you look at the graph in the middle, the pink line shows that we're making improvements from the bit that we can do, which is the job cycle time to where we describe clear at scene. So that's for non-conveyed patients. But the overall job cycle time for when people are taken to hospital is going up. And it's been going up now for a couple of months, and that's very much linked to the graph on the right hand side that shows the hours that we're losing in handover at hospital. And just recognising that from February, where we were at 560 hours lost, we're now at 960 for the week ending the 25th of July, and it's an increasing trajectory. The orange line, and I appreciate it's very small and everyone has got the slides, but is actually the percentage of handovers that are over 60 minutes as well, which also, as you can see, is on an upward trend. Just to note that there is some real disparity across hospitals. St Richard's is one that consistently delivers really well against handover times, but it's a very mixed position across the region. Lee, next slide, please. Patient and staff safety and welfare engagement, of course, is absolutely paramount at this time as well. And I've talked briefly about some of the REAP4 and BCI issues, but it's about the suite of measures that we take. This is really about getting staff to be as frontline as possible in terms of engaging and undertaking patient-facing duties. Within the Emergency Operations Centre, taking additional actions to manage that risk in lifetime, so risk stratifying call queues, and really taking a number of additional actions that I know Scott and John will talk about later. We've restructured the daily strategic and tactical oversight and command calls that happen first thing in the morning. They always start with a focus on patient and staff safety and welfare, but we've done that to, again, enhance the oversight and the command of the ongoing delivery of the service on a daily basis. Handover huddles, they're ongoing in EOC and 111 and critical at doing that handover. When I talk about meal break, and it was mentioned previously, we're really good at making sure that staff get their meal breaks. We are really trying to make sure they where they can get back to their own dispatch desk, they do, but with a greater travel at the moment, it's actually of great importance that they get the break, and they get the break potentially quite local to where they are at the time. The other piece is the end of shift overruns. We know that there are times where crews are stuck at hospital and waiting to hand over, and that's creating additional shift overruns. And our local management teams are very good at supporting and moving crews around between patients and vehicles in order to ensure those that are closest to needing to be off at the end of their shift get off first, even if it means that they have to swap patients around in order to be able to facilitate that. So really trying to support staff to manage both the meal breaks and the shift ends. And then, of course, we continue the reviewing of calls, particularly those extended call times and around tail audits and triple breaches. Lee, next slide, please. So the performance improvement plan, this is a 12-week plan. We're in week 12 at the moment. The intention and the activities within it were very much looking at using the existing resources more efficiently. Two parts really, the shorter term, a 12-week, which of course will run on now into the summer, and then very much building on that for a much bigger piece of work going forwards, and that until in turn will support the longer term structural review we will do. But this was very much a case of trying to stabilize and mitigate the risk of deterioration in the short term. Next slide, please, Lee. So there's a whole significant structure of governance around the performance improvement plan. It was co-designed with those who own the actions within it, and we all agreed baselines and targets. So that was a really important place to start. So it was something that was owned and understood by local teams all the way down to operational team leaders. The PMO team support it fully, and we've got all the right structures in place in terms of smart sheets and tools and etc. to make sure that we're tracking everything. The senior ops teams, we review it on a regular basis, and obviously talk about actions on particularly those where they're going off track to what we can do to pull them back in. And the final point just to note here is that when Scott and John do their presentations, they will talk about performance optimization plans. These are very comprehensive plans that are done with have been put in through 111 and EOC, and that feed into the performance improvement plan, so that metrics in this plan are the same ones but a slightly smaller subset of them as those in the POP. So they're all integrated and they all flow through, but they will have greater details that are more operational and tactical within their plans, whether the performance improvement plan is a more strategic oversight. Lee, please. So I've just put this in. This is a very busy slide. I'm not expecting you to read it all, but this is very much just to show the kind of clarity and the structure that we have in place on a weekly basis to review each of the metrics in terms of overall trends, in terms of improvements, both looking at the target and against the baseline of where we started in April. The plan is very comprehensive. This is just a small part of one of the work streams for EOC, but there are multiple work streams for the different parts of the service line. Lee, please. Thank you. So really high level overview of the different parts of it. From a 111 point of view, we've particularly looked at three areas around resourcing efficiencies and the referral, sorry, apologies, that bottom right left hand side should say recruitment. So they've been very, very successful in recruiting, had significantly had high levels of completion of courses, which is really great, good indication of positive recruitment of the right people, and good training and support to get those staff through. We are also doing well at meeting the resourcing levels for, the efficiency levels for call taking for health advisors, but we've got more to do in terms of resourcing across the hours of the day and in totality. Next slide, please. EOC, again, positive news around clinical staffing, more to do around EMA levels, and dispatchers also doing better, but what we're finding is variation across hours of the day rather than across as a total for the day. Calls being taken by EMAs are meeting the 12-week target already, which is a really good news story, and that is linked to the amount of time that we're supporting them to be on the calls rather than taking them out of unavailable time. And for just to let you know, unavailable time is where they mark themselves unavailable on the phone, and that could be for a range of different reasons, including safeguarding, reporting, needing to talk to one of their team leaders, breaks, etc. But it's about actively managing that for it to be an appropriate length of time. One of the things that we're noticing at the moment with a reduction in the availability of resources is that our vehicles are needing to travel further. We've mentioned this previously, but it's really important that we work with the dispatch teams to really try and improve that tasking so we mitigate that travel time as best as possible. It's not an easy fix. I think now that we're looking at it more, we understand it more, but we have, when I say here, inconsistencies across the dispatch desks. That's also mirrored because we have inconsistencies at staffing across those dispatch desks. So we're not starting from an even playing field. When you've got disparities in resourcing, it becomes increasingly difficult to dispatch them smoothly and try and maintain them with their own dispatch desk a bit better. Resources per incident, this is a national metric that all ambulance services measure. 5 of the 11 weeks we've met the target. It does fluctuate occasionally. It's only one level of deviation from the target, but actually even that one level has a marked impact on overall resourcing. So again, something that we measure closely. Lee, next slide, please. I've called this additional areas. So these are specific actions that don't neatly fit into either EOC 111 and field ops. And as much as private ambulance position is there, we have paramedic practitioner hubs who are supporting doing crew callbacks, really essential at the moment when we know that GPs are struggling to at times to have enough capacity, particularly in the out of hours, to get back to our crews where they need support and advice. So working with them to really try and optimize the staffing. Good news from critical care paramedics. So they've really stepped up to increase their utilisation, not just at the calls that they are classically designed to attend, but actually supporting a greater breadth and depth of calls. So good news there. Community first responders, another good news story. We're really trying to increase the utilisation and the number of incidents they're attending per hour that we have them out, and we're seeing some improvement there as well. The final thing is a tech thing. I've called it a nudge. So our crew staff carry radios that used to beep at 10 minutes and 15 minutes when they've been at hospital, just to remind them that wrap-up times we needed to get them moving. And there's lots of evidence out there that what you try and do is do small nudges rather than big steps. So we moved it to 9 to 14 minutes. And I think whilst there was a little bit of uncertainty initially, I think overall what this has done has helped contribute to some of that, to some of the work around the wrap-up times. It hasn't delivered everything that we had wanted, but I think part of that has been, it goes back to the position we're in with the pressure that people are feeling and a bit of fatigue that's kind of offsetting it somewhat. Lee, next slide, please. So last one from me is around field ops. So specific actions that we've tried to do, we've really tried to increase our see and treat rates. This is all about not only being a system partner and trying to make sure that only the right patients go to the emergency departments so that they can manage their flow better. It's also the right thing for patients. We need to make sure that where we can, and it's the right thing to do, we don't take them into an emergency department, but we consider either referring them on either back to their own GP or to a community service, maybe to a minor injury unit or that kind of location. So we've seen some real improvements in see and treat rates across the whole of the southeast, but we need to recognise it's also dependent on the resource. The community and referral services available, because if they're not available, then it becomes the default position, inevitably becomes A&E for everything from mental health to, you know, minor wounds that a district nurse could deal with. And I know that some of the longest waits that we have been reviewing and looking at have been for things such as block catheters, etc., which inevitably, you know, they come in they come in the wee small hours when capacity to take anyone anywhere but emergency department is often very limited. Hospital handover times. All hospitals except St Richard's are showing a worsening in handover times. This is despite the fact that my teams have done specific visits in collaboration with the A&E management teams to each of the departments to understand if there's anything that we can do collaboratively to make it smoother. But St Richard's is the only one at the moment that is sustainably meeting the 15-minute target time, with a couple of them having, as I've said here, very significant deteriorations in their handover time, the worst one being over 10 minutes difference since the baseline of April. We've also done internal work looking at wrap-up times and late sign-ons, small improvements being seen, but that's what we're looking for, small improvements week on week, but not necessarily on track to meet what we thought would be the 12-week target. But I think it's important to note when we started this 11 weeks ago, we were in a different position in terms of resourcing and looking forward to where we thought this was going to be only 3 months later. So I think that's my last slide from Field Ops. What I am going to do is now hand over to Scott, who is next, and I think is going to talk about EOCs. So there might be a minute because I think Lee might be
changing the slide deck.
Changing the slide deck.
Thank you very much, Emma. Thanks, Chair. Lee, are you going to run the slide deck, or I can do it? Perfect. Thank you. Okay, everybody. So just get this loaded in. Thanks, everybody, and I'll try to be quick. This obviously is to provide an update on the current situation, why we are where we are, and our actions. A lot of information is going to be provided, and obviously you should have copies of these. I'm going to focus on sort of some of the key areas in today's presentation. So if we could go to slide 3, please, Lee. So this first slide really just focuses on some of the key challenging areas we've got within our NINDS EOC. Ambulance activity, as you can see, they were one of the highlighted. Nationally, it's had a significant increase where call demand obviously is a key indicator, a gateway. It's not just demand, it's also the volatility in profile and how it affects our own resource capability. It's not just our patients that get unwell, it's also us ourselves when we're exposed within a pandemic. And then on the bottom right there, obviously responding to the significant challenges in having to be versatile through this pandemic, obviously to provide service with all the isolation guidances we've had, social distancing, and all the digital measures we've had to try and introduce within the last sort of the last journey of the 18 months. Can I go to slide 4, please, Lee? So obviously in slide 4, this really is just giving a indicator of the activity we've seen, particularly over the last 3 months. We've seen duplicate calls increasing, call back to service having risen to over 26% of total volume. Over 52,000 calls we've taken in Q1. And it's just providing some of that understanding of where we were in 2019 to where we are this year in 2021. And the impact it's having on particularly on our call handling, as you'll see coming in now. So the next slide slide 5, please, Lee. Now, a call answer moved from a challenged position 18 months ago to a sustained service level where we was meeting our contractual requirements consistently. Whilst challenged in this period recently, we have been able to provide 999 call handling support for Scotland, YAS and LAS. So we've been offering our call handling support for that at the earlier part of this period. This slide is to give an indication where we benchmark against our neighbouring services, and you can see the top slide there on the right, where the pressures come in, they impact our region or our area consistently. So it was through February, March and April they were lower, but in May and into June we've seen those impacts of that demand affecting all of the providers, both nationally in red and regionally within the other three stacks that you can see there. Okay, thank you. To slide 6, please. As I believe Emma's outlined and Philip mentioned also, the introduction of CAT 3.4 national pilot went live on the 25th of May within CCAM. This is a fantastic opportunity for CCAM as one of only 2 pathways providers nationally to be included in this pilot. With the second phase pilot we've gone in with, it's starting to see some we're starting to see yield the results of that, being able to have clinical early eyes on for CAT 3.4 validation to an appropriate outcome, and we can see those hear and treat numbers now consistently increased, and obviously we are engaging at least twice a week with their national partners, with SCAS, who are our allied partner in this, being a pathways provider, understanding the types of cases we can really focus at, where we can make a difference and be efficient with this work as well. As in clinical, obviously what we're doing is we're reviewing all of our seconded staff. We're in REAP 4, as you're all aware, and we're starting to utilise these staff to how we can support Hear and Treat further. And I'll be talking a little bit more later about the introduction of PACS, is an NHS Pathways clinical consultation module for our PPs, and how we expect this now to make even more of an improvement to what we can do with our Hear and Treat. Thank you, Lee. Going on to slide 7, please. So some of the staffing challenges, what we're facing with at the moment. Now, the current staffing is 244 whole-time, they should say EMA, sorry. Now, sickness abstractions has been running high. We've noticed well, what we did through the nines in recruiting in EMAs was we went over the budget in the context of the fixed line, because we had additional funding to support call handling in through the pandemic. This was a great opportunity for us, where we had a lot of furloughed staff join us from especially within our Crawley footprint. They joined us, but as furloughs ending and staff are now returning to their work, we start to see some of those staff return back to their previous employment. So we do have a continual recruitment cycle for EMAs. I'd like to draw attention to the bottom chart in the COVID sort of impact. The green sort of stack charts there you can see there is our COVID abstractions, and as you can see through December that went up, it's tailed off, and it kind of mirrors the national picture that I'm sure many of you see on the news. And that is our staff that are not able to take calls. It is a challenge that we're having to pick up, and I'll highlight those in the pop a bit later on. Next slide, please, Lee. So this is the clinical staffing for EOCs now. So I think it's worth pointing out here that chart does go back a long way purposefully. It's about understanding our key core clinical staffing for all of our EOC functions. This is our CSNs and our clinical supervisors are at full substantive levels and have been throughout the pandemic. Yes, they have been impacted by the COVID abstractions, again, as you can see on the bottom chart there. But I think it's important to point out that within the pandemic, we've seen very little movement of clinical staff across roles. They tend to have stayed in their jobs, and only now we start to see in our recruitment pipeline some early indicators of clinicians that are willing to, that wanting to come and join us. So we look to see those numbers improve even beyond where it is now. Thank you, Lee, and go to the next chart. So just briefly, I'm going to go for a call audit now. So obviously we have been going for a very difficult period, but throughout the whole period we have maintained our quality focuses, particularly in call audit, ensuring that our call handlers and clinicians, so the top one is for non-clinical audit completion and compliance, and the bottom one is for clinical pathways audit completion and compliance. We do have it for our MTS, that's Manchester Triage solution audit, and it's in the same place. So we've just continually been able to hit our requirements in audit for all roles within EOC. Thank you, Lee. I'm going to go to the next slide. So obviously, as within part of our quality focus, we continue to monitor where we are with serious incidents. And as you can see, since January 2021, 17 serious incidents have been declared through the CCAM-SIG, serious incident group. But one of those was de-escalated. And they're all going through the investigation process. We continue to allocate the resources to those. And obviously, so we can get the learns from that and put them in place as quickly as possible. Thank you, Lee. Slide 11. So on slide 11, this is obviously looking at the risks. So within our EOC, we, like all directorates, we monitor our risks through Datix. We currently have 10 open risks. As you can see, 3 of these are already reached their risk level current, which is the target, and they've matched. All 3 of these now are being proposed for closure and are going through the closure process. That's within our 999 EOC senior leadership team and quality and patient safety group meetings, where those will be hopefully then closed down. And we obviously continue to review all risks regularly, and as you can see, they've all been reviewed and are fully updated. Thank you, Lee. As Emma's outlined, oh, sorry, no, we're on, I've skipped a slide in my deck there. Sorry, we're on the performance staff engagement. So we did obviously the staff survey 2020. Key themes identified: morale, staff engagement, and quality of care were the key areas we needed to focus on. And we've looked at all of those in individual ways, and we've put in several actions to improve it. Many of them within our performance optimization program or plan. Sorry. We're looking to do an external culture review to take place, interviewing of 30 staff across East and West EOCs to unpick these 3 issues in morale, EOC management skills project, and quality of care project. We're undergoing a rota review design where staff have been engaging fully with that. One last night again, and they're very successful. Staff we're able to match our rotas to our demand, and that's working very well. And obviously I've got a EOC webinar staff committee, and all of our EOCMs, a large number, are taken to 360-degree surveys for the Leadership Academy framework, and that's all in place as we start the journey down improving those positions from staff engagement. Thank you, Lee. So further on the EOC performance optimization program, as Emma said, we're not going to put it up here. It's a very in the weeds, operationally delivered program where all of the people that, as Emma said, were the key stakeholders in developing where we know we can make the biggest impact with the work streams, and the people that wrote them are the people that are delivering those work streams. So it's got, each of them have clear indicators which feed into the overarching plan that Emma obviously holds. Going to go on again, please, Lee. So the EOC Performance Optimization Programme is supported by the Trust, as we outlined, with PMO. So we have weekly meetings, and they are fed in with separate task and finish groups, which also feed into that with critical pathways understood by all stakeholders in those. We have allocated resources from the 999 EOC leadership team to make sure we have to deliver those milestones and that we have the understanding of any challenges early on so we can overcome them. And the tracking, as again Emma's outlined it, we have smart sheets which we're all able to get into and understand where we are on our deliverables and any sort of key dates that could affect the critical path of that delivery. Thank you, Lee. Going to go on to the last slide. Really, this is just outlining some of the EOC patient safety measures we've either had in place or that we've been developing and have improved upon, and a lot of them are referenced in the POP. I'm going to go into a couple of these. So clinical tail audits. Since January this year, we've had to do 2,913. That goes up to the end of May. In June, we are still audited in June, but we're 90% there. But we've completed 100% of those of our clinical tail audit requirement. As I mentioned earlier, the CAT 3-4 national pilot, with over 10,000 cases being eligible, and we've seen those start to now come out with increasing hear and treat outcomes, and that's starting to have a significant benefit. We've introduce ITK referrals with the functionality enabling direct booking from 999. So John will go into the direct booking, obviously in 111, but we are able to direct book from our 999. When we get a UTC outcome or a GP, we can book that appointment into their relevant services. And obviously this really does help us in managing callbacks as well. If the patient knows they've got a service and a time frame, they can go and see that service in. And as mentioned earlier, PACS, this replaces Manchester Triage, will be replacing Manchester Triage and Senior Clinical module. It's a clinical consultation module aimed at more senior clinicians. I'm pleased to say that Emma's completed her training and Fiona's completing her training. A lot of the exec and the medical directors are supporting us in how they can support in our EOC clinical, and that has gone out across all of the PP hubs as well, with a rigorous, robust training schedule and plan, and we've got a lot of staff being booked into that. These are going to make a significant difference in our sort of virtual telephone triage model for clinical. So that's it from me, from 999 EOC. I'm now going to hand over to John, who's going to take you into 111. Thank you all.
Okay, thanks, Scott. Really helpful there. So Lee, if you could just pull up 111, please. That's great. And I think it's really important, just before we start going into this, is a really busy slide, but it's an important one. Just prior to that, I think it's really important just to identify how important the collaborative work and integration piece between 999 and 111 over the last 18 months has been. In terms of bringing that resilience, looking at sharing best practice, looking at upskilling both teams and actually working in a more coherent way across both services. It's absolutely been integral to our ability to deal with the demand and activity we've seen across the, especially across the COVID pandemic. And I'll talk a little bit about that later on. So this is an incredibly busy slide, and it's important because this just gives you a bit of context around what this service has had to cope with, the 111 service, over the last 18 months. Essentially, we've moved away from what would have been traditionally called a 111 service or a signposting service into now we have a fully functional integrated urgent care clinical assessment service, or CAS as we call it. And the roles are very different. Rather than essentially doing an initial triage, ruling out life-threatening situations and then telling the patient where to go to thereafter, we are now going down more a consult and complete model, or actually booking in that patient to the most appropriate other alternative provider. And this is a fundamental change in terms of how we operate. And what you see on here are all of the changes we've applied. No, actually, not all, most of the changes we've applied across the last 12 months. To our 111 service in terms of either the computer-aided dispatch, the CAD Cleric, or in terms of NHS Pathways itself, the triage assessment tool that we use. And just to bring a flavour of it, we've actually brought in two services or two organisations, CCAM and IC24, to work collaboratively as one service. We've taken two systems, and over that period of time, we've moved it onto one operating platform. We've introduced electronic prescribing. We've introduced 111 first. We've introduced the digital interoperability toolkit, digital roadmap across the region. And there have been so many other changes that we've brought in over the last 12 or 18 months. So it's been a huge time of change. And if we can move on, please, Lee. And what I've identified here are some of the challenges we've faced. And rather than going through all of them, I've picked out three key ones just to bring to your attention. The first one is around activity record and is at breaking level. It's at huge levels at the moment. We are currently, as you'll see later on, 50% above the activity that we are contracted to receive. It is absolutely uncharted territory. And just to give you an example, on Saturday we took 6,500 calls. On Sunday we took 5,000 calls, more than 5,000. On Monday we took more than 5,000 calls. To give you a bit of context, on the corresponding 3 days last year, 2 years ago, sorry, we took less than half of that on some of those days. So that just tells you how far we've moved in terms of the sheer scale of activity we're now dealing with. Then moving on to abstraction levels, they've been really high. This is a team, the 111 team, that's been under tremendous sustained pressure for a long time. And whereas in the nines, we had some respite during the first lockdown, where activity really tailed off because people didn't want to contact 999 and didn't want to have an ambulance because of the fear factor associated with that if they had COVID. everything went into ones. And what we've seen over the last 12, 18 months is a transition nationally, especially with the advertising that's been happening around activity being pushed through 111, be that some primary care, certainly urgent care, and even emergency care. 111 has become somewhat of a catch-all for activity coming through into the healthcare system, and that's put pressure on our workforce, be it through the pressure and stresses of working, or in addition, also COVID's had a huge impact, as you'll see later on, with abstractions relating to not just the Kent variation, but also the Delta variation of COVID. And then finally, as I've touched on earlier, a huge amount of change with the CAS role itself. We've gone from being this signposting service to essentially becoming the conductor for the wider healthcare system, and we are holding that risk essentially as a clinical sponge. So rather than having patients queuing out the block in terms of acutes, what we do now have is a virtual clinical queue where we avoid that risk of nosocomial infection, especially during COVID. We have patients sitting in a virtual queue where we have a multidisciplinary clinical team who are assessing those patients and who are risk rating those and risk managing them. But of course, that brings its own inherent challenges in terms of the size of the demand and pressures upon us. Okay, so moving on to the performance challenges itself, and I've captured here just the activity itself. And as you can see there, the higher blue line in the graph is what we're currently facing. The yellow line is what our rebased activity is down as, and then the actual darker blue line at the bottom is what the original contractual target was when we started this contract on the 1st of October 2020. So you can see where we are. It's been a huge challenge. It's necessitated a huge amount of collaboration with not just commissioners, but also between nines and ones to make sure that we've got the effective workforce at the right times, and looking at pooling some of our skill sets around planning and around training to make sure that we've got the right people in. And I'm really pleased that we've now got a really robust recruitment plan, which, as you can see with the top element there, we are now at the levels where we are the new rebase level, albeit it's not enough at the moment to currently meet the huge demand that we are facing. Okay, so moving on to the next slide, which is around performance and call answering. So traditionally, 111 was measured essentially two key measures. One was abandoned call rate, one was call answer in 60 seconds. With the new NHS England aggregated data collection metrics that we have, rather than call answering be measured as 60 seconds, it's more around average speed to answer, which is what we are measuring going forwards. But I've captured this here just to show you from a traditional point of view where we are, and you can see it's been a really difficult picture over the last 12 months, where we got to a relatively positive place in March, and then it's actually been really difficult, especially in the last 3 or 4 months, and that has been principally driven by the huge volumes that we've been receiving, which are disproportionate. However, I think it is really important just to note that most recent week we were 10th out of the 20 services nationally, which is a really positive place to be, and we've definitely seen a marked improvement over the last 4 to 6 weeks, and that's actually been driven compared to our peers, and that's actually been driven by the actions that are in the performance optimization plan, which we initiated 3 months ago, which we're now seeing the benefits come through, especially around recruitment, which is great news. Okay, so moving on. This is clinical contact rate, and again, this is a really important measure from NHS England. This is showing and giving assurance that with patients are having an appropriate clinical contact or contact with a clinician in a timely way. And as you can see here, the national target is 50%, and we are here, and we've captured here against our neighbouring services, and you can see here we're tracking at about 46%, and the national average is about 41%. So we are consistently above what the national average performance is for this measure, and this is a really good news story. This is about us actually making clinicians available, making contact with patients, and trying to find the best appropriate clinical outcome for them. So this is a real sign that we are moving in the right direction, and that the purpose that this service was commissioned for is doing its job. So moving on. So this is about ambulance referrals, and again, this is some really positive news. Yes, we're an ambulance service, and yes, you'd expect us to be focusing on ambulance referral rates from our 111 service to the nines, but actually we're not just doing that, we're doing it in a way which is making a huge difference. And as you can see here, we are consistently below not only the national average, but some of our fellow providers. We use Neas here as an example because they're on the same operating system as us, and they have the same operating model as us on Cleric, and also South Central, who are our nearest ambulance trust working near us. And you can see here the difference that we're making. And how we achieve that number, that's not even just because of the POP. This came about 18 months ago when Philip first joined the trust, and he was particularly passionate about us having a real grip around our 999 validation in particular. And we've taken those learns and we've really embedded those in terms of the culture within 111. So now, consistently on a daily basis, we validate more than 90% of our Cat 3, Cat 4 non-emergency ambulances, and that tends to be either somewhere between a 60 to a 65% downgrade of those particular cases. And every one that we stand down is one less ambulance that we're having to push into our own 999 service, and thereby alleviating the pressure on our crews who are already under immense pressure. Okay, moving on, please. This is around ED performance, and again, I talked about the purpose of the CAS earlier on. It's about protecting the wider system. It's about being a system player and helping maintain patient safety, not just across our trust, but across all of our patients across the region. And as you can see here, we are again consistently below the national average, which is good. And we are down there in terms of the best performers around our ED referral rate. And essentially, this has been driven by the behaviours of our clinicians, the behaviours of our health advisors at the front end, and it's also underpinned by something that we call DAB, direct appointment booking, which I'm going to talk about in the next slide. But what we can see here is that with those validations we're doing of the emergency department dispositions and the work we've done collaboratively with commissioners especially, we've absolutely managed to really drive down our ED referral rate. And that actually pertains to very specific acutes. At times we've worked with some of the Sussex acutes and some of the Kent acutes when they've been under real intense pressure to target all of those referrals so we can try and manage those and alleviate the pressure, moving that activity, either consuming it ourselves or putting it to alternative providers, so that we can just ease that pressure upon those particular under pressure services. And moving on. So this is the slide I was referring to just now. This is about direct appointment booking, and this is quite a seismic change. As you can see here, back in a year ago, we were doing about 2,000 or 3,000 direct appointment bookings a month. We're now consistently doing 26,000 every single month. That hasn't been achieved lightly. That was achieved through a huge amount of collaborative work with commissioners, building a digital roadmap, doing all the testing, making sure that we brought together all the threads of that digital chain so that it would enable our people, call handlers, clinical and non-clinical, to be able to assess patients and then make sure they go to the right appointment rather than people just rocking up to emergency departments. So this is an absolutely great news story in terms of what we're doing around making a difference to the system. Okay, moving on. And here we look at recruitment. And as you can see here, on the top left-hand corner, we've actually got to a level now where we are almost at substantive levels against our contractual levels. However, you can see here we have had really high abstractions, and the bottom graph in particular shows the impact of the Delta variation of COVID being a real issue and a challenge for us. And also we have some challenges around onward going recruitment, which we're working really closely with the HR team to address. But on a positive note, we have managed to get a real step change around recruitment in the last quarter in particular. Okay, moving on to clinical staffing, and again, this is a really critical slide which probably doesn't tell the story that it should do. We've gone from having no GPs 12 months ago to now having a fully substantive level of 31 whole-time equivalent GPs working. On a Saturday, you'll find 50 or 60 clinicians in the multidisciplinary team working. That's been a real labour of love and working to make sure that we get the right skill mix, with a huge mapping exercise working with NHS and commissioners, and then a huge recruitment drive working with HR to make sure we get those right clinicians in the right place at the right time. We're not quite there yet. We're about 85% of requirement, but when you consider where we've come from, that is a massive step change over the last 12 months. Okay, and then moving on. So, as Scott alluded to earlier, it's really important maintaining that quality focus and quality assurance. And one thing that I'm really pleased with is both for 9s and 1s, we have not let the focus and grip around audit slip. So we have maintained that absolute consistent level of audit across the last 12 months, making sure that we are at levels there or thereabouts with our license requirements and in terms of making a difference. And it isn't just about doing the audit, it's about what we do with the audit. So we report on it, we do thematic analysis, we share that with our people each month. We also share it with commissioners and other external stakeholders. So there's an absolute drive for continuous improvement, and audit is at the heart of that as we do that. And we've actually changed our operating model so that we have senior health advisors now who are specially skilled health advisors with additional skills around coaching and around auditing, and that gives us a real resilience there around, even at times of pressure, being able to continue that audit function. Okay, so moving on to complaints. So complaints, this has been really challenging, especially recently, and as you'd expect with the massive step change around demand, we have been more challenged in terms of answering calls in a timely way, and that has absolutely coincided with a rise in complaints. On a positive note, we are in a place now where going back to 12 months ago, we didn't have an active patient survey in place, and as you'll see in the next slide, we now have that. So we're able to get really clear feedback from our patients and the service users to understand what we need to do differently. This is a challenge for us in terms of complaints. On a more positive note, as I said, the thematic analysis that we do with audit, we also extend to complaints. We share that with commissioners and external stakeholders. We share it with our own people, and there is a clear plan to act upon the feedback we get from and the learns we get from our complaints from our service users. The other thing that I think is really important to note is that we don't breach on any complaints. It's something that we are absolutely clear on. And as you can see in the slides here, the area that's probably or is the biggest concern is the timeliness or delay in a callback, and I think there's an element where we can understand that given the pressure that we're under at the moment, and obviously the staff delta that I've also referred to in terms of the excessive demand we've got at the moment. Okay, so moving on to serious incidents, and again, just very clearly, we are maintaining that focus on all incidents, and especially serious incidents. We're doing the investigations. One serious incident was always one too many. However, over the period since Christmas, we've had 4 SIs declared, which and we've worked really closely with the nursing quality team to make sure that they're really good investigations, and more importantly, that the actions that come from that make a significant difference to learning for us. How do we improve the service as a result, and we benefit from the insights that are gleaned from those investigations. Okay, so moving on, and this is the patient survey I referred to. Deteriorating picture in terms of overall satisfaction, but we are in a place now where we can measure and we can evaluate, and we are obviously working really closely to make sure with all our teams to make sure that we are putting in place the actions that are required to turn this around in terms of the overall satisfaction, to drive it back up to the levels we were in January and February, prior to when we had this massive surge in activity at the end of March. Okay, and going on to risks. So absolutely, risks are captured and reviewed weekly at the senior leadership team meetings in both 9s and 1s. And actually, you can see here the number at the moment attributable to 111 is under control. They're all being managed as best we can. The biggest challenge, I suppose, is around the move to Coxheath and Ashford, which is rated here. However, there are mitigations in place, really strong communication with our people, and links in with the programme board for the Kent Medway move. And it's something that we're obviously working really closely with HR on, so that we can manage going forward to mitigate that particular risk. But all of these risks, as I've said, are covered within our senior leadership team meetings. And moving on. Staff engagement. So this is absolutely key. We undertook a deep dive, external deep dive last summer, because we were going through a huge amount of change and challenge at the time, getting ready to mobilise. And we've taken the learns from that and initiated a culture change programme, which is absolutely multi-stakeholder. It's not led by the leadership team. It's led by the service coordinator, but it's got absolute full representation from all the key stakeholders across the trust. That meets regularly. It is sponsored by our Executive Director of Operations, Emma, and that is really the roadmap for us to listen to our people and to make sure that we are acting upon that feedback and our people feel they have a voice. That's led to potentially, well, not potentially, uniform is going to be rolled out across 111, so it's more consistent with our Nines colleagues. We've obviously got the soft skills development project as well ongoing, and we've got the management development project as well for 111. So there's a huge amount of work that's been caught underneath that umbrella of the culture change program. And I've also captured here about the additional webinars that we do. And one of the key things which I will talk about in the last slide is around our Ask 111 leaders, which is something that we initiated about 18 months ago. We've maintained that every single week throughout the COVID, throughout all of the challenges we've had over, including REAP. And that is an opportunity where all colleagues can feed in their queries or concerns, and the senior leadership team meets together and they respond to those in a transparent way. And that's really important to us in terms of our modus operandi as a leadership team for this particular service. Okay, so moving on. We've obviously got the performance optimization program, which is in place, and that's been in place now, I said, just over 3 months. And that is, as Emma said earlier on, it's a really detailed plan on Smartsheets, and it captures loads and loads of actions which are measured, and there's a clear milestones against them, clear actions. And actually, we meet weekly with full PMO oversight. So we meet fortnightly with full PMO oversight, and we have commissioner representation as the stakeholders on that. We want our commissioners to work with us. They're part of the solution, and that's absolutely key for us. Okay, moving on. And again, without dwelling on this, we've already talked about this earlier on in the earlier slides. In a very structured way, this is how the program is working. This is what we're focusing on, and this is where we end. This is our key tool, we believe, in terms of improving that performance overall and consolidating the gains we've made over the last 3 months. And then moving on, Lee. And then this is just capturing around the methodologies used. So rather than being just an action plan, it's really structured. We've used best principles in terms of how we actually link all those interdependencies together, including the risks in terms of capturing that data and then embedding those learns that come from this particular program. And it's something that we've then applied to 999 as well, with the learns we've had initially with the 111 POP. So moving on. So in terms of the so what bit, I suppose, so we've talked a lot. I've talked a lot about what we've done and all the challenges. So what difference has it made in terms of maintaining patient safety? So rather than going through all of these, and I could have made this about 3 times the size of this slide, I just want to pick out on 2 or 3 things here. First one is around looking at CAS risk management and upgrades, system upgrades. So what we've done is we've looked and learned and changed the way that we manage the clinical queue in the CAS. Yes, we've got large queues, but actually they're risk rated, the queues. The clinical navigator is supported around giving them better tools to be able to manage those in terms of color coding and prioritizing against the acuity and the risk of those particular cases. And that's really helped in terms of our management of risk. We've had in place a patient safety quality deep dive, which we did in collaboration with Nursing and Quality and commissioners. And that was really successful because it was an issue that had been identified. We put in place the deep dive. It was incredibly comprehensive. And as a result, that's led to the CAS daily breach audits, which is a really robust process where we're capturing those breaches. And that's actually made a real significant tangible difference in terms of our services responsiveness and our ability to identify the longest waits and the risk and how we manage those effectively. And finally, in terms of some of the patient safety developments, we have got a really robust governance framework and leadership framework in place. So we meet daily with our IC24 colleagues in terms of huddles 4 times a day. We have a daily meeting with all of the key operational leadership team and clinical leadership team. And then we have weekly meetings with IC24 and CCAM around with the operational senior leadership teams and the governance key stakeholders, including the medical directors. And that's been really, really important to facilitate important changes at pace, and that has been really, really beneficial to embedding quality and improvement going forward in the service. And then finally, some of the successes and good news stories. So rather than again dwelling on, there have been loads I could talk about here, but I think just to bring us back, we have worked incredibly closely with our 999 colleagues in terms of managing and supporting them in the managing demand and supporting them in the field around HCP callbacks, in terms of how we've managed in terms of Cat 3s and Cat 4s and finding alternative locations to ease the pressure on them. And we've done a massive piece of work with what we call the call handling integration plan, or the CHIP, which is around looking at the best of both between 9s and 1s and working in a more coherent and integrated way, which has been absolutely invaluable during COVID. I've already talked about the Arthur 111 leadership team, which again has been absolutely really well received and made a real difference in terms of, we do a so what, so these are the questions that are raised, we give all the answers, and what difference does it make, and we put that on the board and we capture it so everyone can see the difference that their feedback is making when we can make those changes that they identify on the issues they identify. In terms of the improvements of the host system, constant improvements. We've constantly been looking at updating our CAD and looking at how we can maximise patient safety and mitigate that risk. And that's something we work so closely with our Cleric, our providers, our suppliers, and also the critical systems team to make sure that we're embedding all this change at pace, but learning from it and doing that quality assurance improvement. And then finally, the trust has come a seismic way. We've come from having paramedics and nurses 18 months ago to now having a full multidisciplinary team with 14 different skill sets in its CAS. This is a massive change. A lot of the other ambulance trusts have a CAS, but it's actually delegated out in terms of the activity. We do all of that ourselves, pretty much within the CAS, and that's a massive difference compared to other providers. And that's it, Lee, I think. That's great. Thank you.
Philip, what I would suggest is there's a huge amount of information there for the board to digest. What I'm going to suggest is that we take a brief comfort break of 10 minutes to give people a chance to get to think through what they've heard, and also to make sure that we can get into meaningful conversation regarding seeking assurance that all that we're doing is keeping our staff and our patients particularly safe, and we're doing all we can to make sure we're using the organisation's resources to meet the current demand. So if colleagues are content, can we take a 10-minute comfort break to get our thoughts collected, digest the information, snippet information we've had, so we can come back and really get to the heart of the matter at 12:10. Okay. Thank you. Thank you. And what we heard were what was the nature of demand, what was the actual drivers of demand on our services currently, both pandemic and other matters, how we're responding to it and the actions that we're taking, work that we're doing with our system partners and others, and we need to also be to consider any future action. So in terms of questions, can I first of all just ensure that in terms of board understanding that we had a lot of detail about what's driving demand both in 999 and 111 in terms of the public demand currently, and changes in the health delivery system. Are there questions in that area or anything people wish to seek questions on to question before we can go into seek assurance? So we look at the front end of the presentation about what's driving demand. So have the board got sufficient information there in order to pursue? Is there anything else you wanted to clarify at all? So we've all got a clear measure of what the situation we find ourselves in, the actual sort of increases in workload. Let's see one hand there. Howard, let's see your hand. Howard?
Yep. It was really just a sort of generic question around demand. Obviously, the performance cell is going to look at how or implement a system that enables the forecasting as a tool. But presumably it's still very early days, certainly as far as 111 is concerned, 111 CAS, I mean, in terms of our ability to forecast demand. I mean, it is just presumably very difficult. Is that right? I mean, how we are, the evidence is that the actual demand is miles away from what was originally envisaged. So how do we know, it's not going to double again, or, what is the range of likely outcomes, and how on earth do we get a handle on that? At the moment, I just sort of see, well, we are where we are, but how on earth do we manage the forecast?
John, do you want to come back on that point?
Yeah, no, thank you, Howard. It's a really good point. So we work really closely with NHS England, the central planning team. It is fair to say, though, that even they have been taken aback by the the increase, and I talked about it earlier on. To some degree, 111's almost become a national catch-all. So if there's a problem with 999, use 111 online. If there's a problem, you know, with the acutes, go to 111 first. So I think inevitably we are going to see more activity come through to, and it's a bit of the old cliche of build it and they will come. We've built it and boy, have they come. And so I can't answer it all to say. All I can say is that we are working really closely as the national provider group in sharing in terms of our forecasting data, and also working really closely with NHS England. And we do have a forecasting tool, but at the moment it's almost impossible to estimate where we're going to land, frankly.
Well, can I just capture that point? Howard, you raised a really important point. I think your answer, John. We've got a number of things. One, we need to plan for various scenarios for the future, but we also need to be actively engaging our commissioners, which I hope we are, and also NHS England, to say, look, this is where we find ourselves, because currently we're carrying the risk here. And your very eloquent presentation with a summary of the risks, etc., and the rising complaints and serious incidents, etc. That's a risk that's unacceptable for the public, but unacceptable for CCAM. So I think one of the actions coming out of today, really, what we're seeing is, and what you're telling us, is demand is rising. We can't quite predict that level of demand, even with new tools going online, and we therefore need to build into our commissioning profile some level of contingency, or assume contingency for the future. That's one of the things I'd like to make sure we pull out, because I think it's really important for patient safety as well as staff welfare, because the demand is going to increase inexorably. So we certainly note that. Michael, you're coming in with a question?
Yeah, I apologise. I've got two questions. My camera's been disabled, so if you can only hear my voice, my apologies. It really builds on Howard's point, which is it's just seeking assurance on how we are making sure demand is channeled in the right way. And I was really interested in one of Emma's paper, where we're validating, is it 90% of calls in June, 40% were validated as being passed to 999. Does that mean that 60% are appropriate to a different channel of response? And it's the question mark I've got is, have we got that optimization right? Because I see Hear and Treat going up, I see See and Treat going up, but that's where I think we are most challenged, that we've got the right skills and we've got the right type of resource to actually respond to that. That's my first question, David. And my second question, it's a bit off beam, but as I understand it, we do have our heart team, which is our hazardous area of response, isn't it? These are our technically highly trained. I saw some reference in there that they are making their contribution to the increase in demand. But I suppose my other question is, we're doing that in no way that impacts on our resilience to respond if, God forbid, it ever happened again, a major incident that would actually, increase demand exponentially for a short period. And I just want to make sure that that resilience is being maintained. So two questions really from me.
I think John and then Emma, I think, to come back on that, I think. Emma, do you want to go first, Emma?
Yeah, so I was just going to say, you're absolutely correct with what you said, Michael. So the first question is, that's a 111 validation, and I'm sure John will pick up if there's anything further to add. It's a 111 validation. We are consistently above the required target. We're often at 95%, but for the last 11 weeks at least, that I've got data in front of me, north of 90%. So it's a really, really strong performance by our service line. When you say the 46%, yes, what that means is that the remainder, so the 54%, then get filtered off to go to other alternative destinations. They don't end up as a 999. They may end up as a self-presenter ED or book in through 111 first. They may be a primary care, or again going to a different location, such as a minor injury unit, walk-in centre, urgent care centre. So that's fundamentally what it means, and it is a really strong performance from our 111 service. Just in terms of your second question, and then I'll see if John has anything else he wants to add to that. So heart, absolutely, nationally, and all the national directors of ops are all having the same conversation around how we use our heart teams most effectively at this point in time, because it's just not right from a patient safety, patient welfare point of view to have any resource available and sitting there doing nothing when we have patients that we need to get to. So Heart already have a national mobilisation and activation procedure, which includes a breakaway clause, so that if they go to an incident and then something comes in that specifically requires their skills and abilities and specialities, there is a requirement for them to be released within a period of time. And what we would do is we would prioritise them and get another resource down, or an OTL or somebody to come and take over from them to release them. So they are absolutely used now more than they ever have, but we have that breakaway procedure in place to enable them to undertake those duties if we need them to. John, in terms of the first question, anything else that you wanted to add?
Yep, 3 very quick points. Firstly, just about, I think it was Howard raised the issue about funding and talked about staffing and demand. NHS England have announced this week, the central team yesterday, actually, they're going to release 23 million across 111 providers. I think our Philip Astle Finance has got the letter. Don't know quite what that relates to us. I think it's really, really important, though, just to note my perception is that may not be new money. It may be recycled money from what's currently being ring-fenced by commissioners, but I suppose what I would say is there's an identification by NHS England, or an acknowledgement that it is underfunded at the moment to meet demand. Second thing was just around that validation piece, which is really, really important. Yes, we validate 90% every day, and yes, at the moment we are downgrading 60% plus. The 40%, as Emma has quite rightly said, does, and the key bit here is, Michael, it gets direct booked, most of it, into an alternative provider rather than just rocking up or ringing 999 or rocking up into another service unannounced and unheralded. So that's really, really important. And then the final thing is, I suppose, part of this is about our resilience as a trust, and this is part of the integration piece I talked about earlier on with the chip, where we're looking at the integration of 9s and 1s, not disaggregating the services, not mixing the services and removing their own integrity, but actually looking at the workforce and making sure they can work, they're suitably skilled across both work services, so that we've got that resilience built in, so that when we have demand at the weekends, this weekend in the 9s, we move some of the 1s clinicians across and vice versa.
Philip?
Thank you.
Yeah, and it's great work that John's team do, but if we validate these cases and decide that 60% of them can be dealt with elsewhere, that's a fundamental flaw of Pathways. It would be much better if we validated them and they were all right in the first place. So that's work going on in the meantime. But I think it's a tacit acceptance that Pathways is overly safe.
But I think that, again, from the point of view of assurance of the board, it shows that there's feverish activity to ensure every call is a meaningful call, and we're making sure we get to the right resources. And from the point of view, Heart, the hazard area response team, this is our centrally funded but CCAM hosted specialist service, which has to be available for those major incidents, etc. But so in some respects, again, for the board assurance and the public, every available resource in CCAM with a clinical qualification that can be mobilised is being mobilised. So I think it's an important point that we need to capture for the board and to reassure the public, particularly when we're not able to meet the demand. But we're doing all we can, and we're getting more money from the centre to expand 111. I think that's another point we must make sure is captured in terms of our response, and to ensure the board is doing everything it can. I think Paul Brockles, you want to ask a question?
Yeah, that's a brilliant presentation. It's amazing how much you're doing, and it's good to see the PIP working, which is good. My question was, what do you think the next couple of months hold? And not everything's within your gift, but are there 2 or 3 things that you would really like to see happen in that next couple of months?
John, you made John, you made also a point about NHS Pathways not being the perfect answer, as it were. So perhaps the response you can do with that. I think I'd like to see, and Emma, of course.
Yeah, Paul. So I'll just respond. But first of all, I think I think for me, there's a couple of things. I think we are seeing continued strong system working. I alluded to the fact that we have these calls on a Friday, Saturday, Sunday now, that is across the Southeast region. It's not just an individual ICS, excuse me, and that has had some real tangible benefits in the last few weeks of our partners really understanding the pressures that we're under. So I think that continued close focus. I mean, the reality is the pandemic, as it's being described, is hitting everyone. It was in the press about the police. You know, we have at weekends now reached out to fire services who have said, dispatch us to your C1s in collaboration with one of your crews rather than sending 2 of our crews, so that they will be hands-on to support as much as they can. So I think that collaborative effort, Paul, is continuing and is going to be absolutely essential to see through the summer. I think, and it's really difficult. I think our staff are really dedicated across all of the NHS and social care. I think we need people to take their leave. I think we need people to have a rest as best they can, because you know what? We hit September and then we're 3.5 months from Christmas. And we go into winter, and what we really need people to do in this time is, you know, as much as our focus is absolutely making the most out of the people and the staff that we have in at the moment, we need people to use the next, until school goes back, which is what usually the second week in September, we need people to really optimize this time to regroup, create some improved personal resilience, because everyone is fatigued and working very hard. Because we've still got a long run in this with winter ahead of us. So I think there is really something about all of us taking some personal responsibility, but also as managers within the trust, us making sure that we support each other and we support our teams to carry on doing all we can to keep the service as safe as possible, but doing it in a way that also improves some of our own personal wellness with our annual leave and things over the summer. So those are probably the 2 key things for me. And then probably the third thing is just the final thing is, I talked about the structural long-term changes that we need, that we've already started working through in what could this look differently going forward. We still need to do that work and have that capacity to do that thought work around what does this model look like going forward in the next couple of years, recognizing all the lessons we've learnt around virtual responses and all of that over the last few months. So I think those are probably the 3 things: is making sure we're on track to continue doing the work around what does the model of delivery look like going forward, is it in its totality, the staff welfare and general well-being piece, and then the system where the collaborative system working would be my 3 things over the next couple of months.
Thank you.
Thank you, Emma. I think I'll come back to it in further discussion, but one of the reasons we're again having this session today is recognising that we've still got the winter challenges to face, and I think it's one of the reasons why again we need to make sure that our plans are nailed down now, ready to deal with those sort of issues. I've got questions from Tom, Fiona, and then Terry. So Tom.
Thanks, David. So Emma, in your presentation, which fantastic work going on, and I agree with all the things that have just been said, you highlight one of our acute partners as having got it right in terms of reducing turnaround time, addressing the handover issue. So when we're having our discussions with our systems, where's the learning from what St Richard's is doing right that can be spread rapidly across our system? Because that's part of this urgent need to get this right.
So I think it's a really interesting question, Tom, because also recognising that St Richard's is now part of I'm not going to get the term right, but the Sussex Massive Acute Trust. They've all come together. So I would also obviously hope that there would be some shared learning now that they're all under one roof. I think it's a really complex thing. I think St Richard's has some benefits around layout, around geography, around activity. It's not one of our busiest hospitals, which means that inherently, because it has it's a bit like Kent and Canterbury, because they both are small hospitals, they have low numbers of patients we take there, they have generally low flow. It allows a bit more flexibility at doing handovers. The 2 hospitals identified with the longest waits tend to be 2 where we which are major hubs, which we take significant numbers in. So if I'm honest, Tom, I think part of it is a scalability. I think also they've been like this for a long time, and I think they've had some really stable staff. So I think it's become an ingrained behaviour. I mean, the two hospitals that are the biggest troubles in some of our inconsistencies of handovers are not only high activity, but one of them's undergoing massive rebuilding, restructuring. And we are regularly going through phases where different bits of the hospital are open, closed, moving around, that we all work collaboratively to ease the flow as best we can, but it just makes it all that much more difficult in totality. So we do obviously, you know, sing about the fact St Richards do get it right, and QE and Kent and Canterbury too do often as well, but it's more, I think it's more about layout, volumes, and general flow.
I mean, the two most challenged to us are Clean Medway and Brighton,
Yes.
and they're both serving big major urban areas. So there are particular challenges there, and I think the nature of demand and the numbers of walk-ins, they are busy places. However, there's still patients who need care, and currently that care is compromised by delays, and therefore it's incumbent on all of us to work more closely together. That's clearly one of the issues which the board does need to seek assurance on, to make sure those patients that may be in our ambulance technically under the care of the hospital, they're still a patient, and they need the right care, and we've got to do what we can to support
Absolutely.
them.
And Chair, I mean, we have halos at those trusts every single day. The collaborative working that we have at those hospitals is phenomenal, because the team in the AED and our team know that there is no simple solution. We have to do this together. So you know, as much as they are the two outliers, they are probably the two that have the most on-day, everyday engagement between the different teams to try and find collaborative ways through it. So I think it's what, you know, it is what it is, but it's not for everybody not trying. And I know the other challenges being, because I've been on calls, the challenge the hospitals have had over the last few weeks, in the fact that they converted a lot of their wards back to green, and now they're going to having to change them back to red. And that, of course, has created massive issues in terms of how easy and how quickly it is to be able to do that. Yes, you know, just to reiterate, you know, the amount of engagement that's going on is really, really good and really positive at both of those outlying sites.
That's good to hear. And a halo you refer to, I assume that means hospital liaison officer.
It's a hospital ambulance liaison officer.
Person in situ.
That's correct. Yeah, it tends to be one of our OTLs, and they for both these hospitals, that they're pretty much there from sort of 7 in the morning till late into the night.
Yeah, thank you. That's reassuring. Fiona.
Thank you. I was just going to pick up on a couple of other points that Emma made about collaboration. So yes, we are getting good collaboration from the system now. So we're involved in system calls. They are aware of the pressures that we're under. We've had support from the regional medical director, who has co-signed a letter from the medical director in SCAS and myself to general practitioners, which is being distributed through the ICC, to encourage GPs to try and ensure patients that they're referring to hospital make their own way where possible. And we're also liaising with the hospitals to try and reduce the number of diverts and to think very carefully about interfacility transfers, all of which put additional pressure on us. So I think we are working very closely with the system, and they have very much worked with us more recently quite closely.
That's important information, Fiona. Thank you. It's important we know that. Terry, and then Chris. Terry, your I know Terry's having some communication challenges with the local internet. The hospitals may be good in West Sussex, but I think the internet is somewhat challenged. We'll give Terry a chance to sort of see you can come in a moment. Chris, you wanted to come in with a question, Chris Gond?
Yeah, I mean, it's a really just a quick question, and thank you very much for the presentation. I was just looking at some of the serious incidents, and I know it was mentioned that there were 10 which were just about to be closed, and there were 4, I think John talked about, for the 111. My question is, I mean, what planning has there been, or is there a theme between all these serious instances that you can assure the board?
Do you want me to pick that up, Chair?
Please, if you like. Thanks.
Yeah. So a really good question, and something that Quality and Patient Safety Committee is acutely focused on, and every committee have a detailed thematic report on the individual SIs that have been declared, as well as the themes and trends coming from those. Yes, inevitably delay is a theme that we see throughout complaints and throughout serious instances. So that absolutely is a theme and a trend throughout. And we've seen, as highlighted in the presentation, we've seen a bit of a change in SIs from delayed C3s to delayed C2s, and have declared that as a cluster SI, so a group of incidences of the same, and that's currently under investigation, but something that QPS has cited on. Does that give you enough information on that, Chris?
Yeah, I think that's very helpful. Thank you very much.
But I think you make an important point as well, Bethan, around the C2s, and I think it's important that the board are aware of that. We are trying to take action, and we've noticed this difference, and it's a matter of concern, and that's the whole reason we're having these discussions now, isn't it? To minimise harm to patients. Thank you. Terry, have you managed to re-establish contact? Must be still having challenges. And Michael, your hand is raised. Is that your old hand or a new one?
It's a new one, actually.
Yeah. Come in, please.
I just ask two questions. One is, I recall at previous boards the considerable efforts, I think, led by Fiona and colleagues, for those elderly members of the CCAM community that we serve, Preventing Falls project, because that seems to be quite a key issue that we may have to respond to with the frail and elderly. And I wondered, is that project still underway in terms of the work that we're doing? Again, it's the whole issue of demand management. And my second question really relates to community first responders who do make a considerable contribution to CCAM. Are we making a sufficient use of this resource?
Okay, Fiona can pick up the first question and Emma the second.
So in terms of falls, yes, the project is still ongoing. However, it has been impacted with the numbers of staff that we have undertaking frontline clinical duties. And also the involvement of the fire service, who have also struggled to release staff to us. But yes, it still is very much one of our priorities, Michael.
Thank you. Yeah.
And can I ask the QPS to make a particular note of that, and maybe, if we do have a lull or a slight reduction in activity, I do take all your points, Fiona. Let's see what we can do to reactivate that project, well, not to reactivate it, but to make sure it happens, because quite frankly, we're going into winter, and given the queues in hospitals we're hearing about, that's not going to happen. That could be with us for some time. So the challenge is we must do all we can to keep our elderly patients safe, and if we can keep them at home with other support, rather than that's going to be to everyone's benefit, I would have thought. Emma, do you want to add any more comments?
Yes, thank you, Chair. So just to build on what Fiona said, the other piece that we're doing is understanding where the ICSs are placing their priorities as well, whether it be about falls or frailty, but understanding what is being asked for, because part of any falls project working is also the requirement to have the right community resources present for support, because you talked about proactive falls management. That has to sit within primarily primary care and community care. For us, it's what we do when we get to those particularly non-injured fallers, to refer them on, but it has to be done in collaboration with the ICSs, so that there is a really robust pathway that works. And we know that our fallers don't tend to fall during the day, they tend to fall evenings and weekends, so it's also making sure we've got robust mechanisms to enable that information sharing, so that there is a timely response as well. So but fallers without a doubt are an important group to look at. Just in terms of the CFR question, so I think it's fair to say COVID has really impacted our CFR teams. Quite a lot of our CFRs are slightly older, and therefore have had, when we took CFRs off, a number of them also went into shielding or self-isolation for various reasons. And I think it's fair to say that there is a level of anxiety about coming back out while we're all still in this position. They've got PPE, they've got all the support, and we are seeing increasing numbers coming back. The other really interesting thing is when we're advertising to recruit, we are being inundated with people who want to join. So there is real appetite there for people to join us from a CFR point of view. I think what we're looking at is how can we use them as effectively as we can within their current remit, but what else can they do? So it does link to the Falls question. We have in the last few weeks, because of where we've been with resources, also paired up a number of CFRs with some of our OTLs on cars, or to go out and pick people off the floor, so they can go to fallers, because often you need two people to physically manhandle someone in order to assist them to their feet or onto a chair, which one of our OTLs can't do by themselves. But CFRs with support and some training are supported to do that. So that's actually been a really interesting opportunity for them. The other thing is learning from colleagues elsewhere. So London, I believe, has a number of CFRs who are C1 trained and have been out on DCAs with some of their staff. And it's very small scale. They don't drive on blue lights, but they, in essence, fulfill a similar role to when we have had firefighters and military out to provide driving and support provision with one of our clinicians. So again, something we're exploring. Obviously, from those, for a CFR point of view, they're part of our team anyway, and they do have some clinical training, so they would also be able to assist with some patient observations, for example. But I think that's definitely something that we are currently looking at as well.
Thank you. And before I bring in Lucy, can I just ask just to pull that one again together as well? I think I'm correct that we work well with the East Kent Frailty team. There's a particularly good example there, I think, where they've got a particularly good programme with a very good, well-organised team there, not consistent across the southeast. Can I ask that in our conversations with ICSs, particularly as they're now coming into post, the chief executives will be appointed in the next few months with a new commissioning round. Maybe this is where we've got to be a bit more proactive as CCAM, saying that there's sort of on our shopping list, as it were, advocate good practice. Here's an example with properly coordinated frailty team and the Falls project. To take Emma's point, we can make an impact on demand and give the public a better service. So can I just have that logged as well in terms of things we're going to do, because I think it's important. And I can ask the QPS, Tom, keep a careful eye on this. We really do need to start to drive some of these initiatives quite hard, I think, because we've patient safety at the end of it. So let's please do that. So Lucy.
Thank you. I wanted to start by saying that the wealth of information and understanding that's come through in that presentation is not something that we would have been able to do some years ago. And so that in itself gives a great deal of reassurance that we really understand what the business we're in. And I agree with you, John, that with the 111 CAS coming in and the on the EOC side, the clinical expertise we brought in, we are in a very different position, which should serve our patients well as we move forward. My question really was relating to the performance improvement plan. So we set ourselves, I think, a 12-week plan 11 weeks ago. And so the slide, Emma, that you've shown are, I'm assuming, pretty much going to be the outcomes of those plans. And the world has changed hugely in that time. We also then had a longer term plan. My question really is, so given where we are today, what is the next step? Because it is extremely easy to look at these millions of dials that we've got. And if I look at it watching this presentation, there are a number of things we cannot change. They are factors that are coming at us. The patient numbers, the hospital handover layers we can input into, but it is not in our gift. There are a number of things that are in our gift. And I suppose I would encourage you to think about separating what we're doing to what we can influence and what we can't. And my question is, in the short term, how do you see where we are today? Because a long-term plan doesn't feel the right thing to do given the changing environment we've got.
Thank you, Lucy. So I think when we started this, it was always an initial 12 weeks. It was never a 12-week full stop. It was a we start with this. We run it for 12 weeks. We see, as you've just said, Lucy, where we've been able to have impact and where we haven't, what is in our gift and what isn't, where we've made. So, some of them we've absolutely hit the targets, and in some cases, achieved above. So we need to go back and actually say that's not the end. Is that just stage one, and we now need to say actually is there more to get out of it from that point of view? I think the conversations that I've had with the teams around the actions that sit under each of those metrics have also opened up some opportunities to consider the next steps. So some of this, for example, we're having conversations about missed C1s. We know that there are certain areas that have missed C1s. Is there something specific we need to do in particular hotspots? So I think it's opened the door to the next phase of this. I think you're right. When we started this 12 weeks ago, the world was a different 12 weeks ago, and I think it's going to continue being that way. So I see this very much as being the reinforcement of the foundations on which we need to deliver the service. So a number of the metrics are really key. The job cycle times, for example, and handover times, but there's also some really interesting work that we need to link in with. So there is a national group which is called NASAT, which is the National Ambulance Strategy and Transformation Group, I think it's called, which sits under AACE, and they are doing some work with a number of the senior clinicians across each organisation. I think Julie Ormrod sits on it for us, looking at what on-scene time should look like. What are the clinical factors that contribute to it? So I think what this initial plan has done has set us a direction, has made some improvements in areas that we've had the ability to influence, has enabled us to also clarify those areas that we aren't able to do as much as we would like, but also I think open the door to other areas that we can include in going forwards. So I guess that's how I see this, Lucy, that this was an initial 12 weeks. We will now go into the next phase, and there will be new actions that come in, new metrics, and others that will probably go on to a monitoring footing rather than an active a program of delivery, because there's probably, as you say, not a huge amount at this point in time that we can do over certain things. Does that answer your question?
Thank you.
Yeah, so Emma, we'll have a recast plan, as it were, phase 2 plan.
So it'll be a phase 2
to the performance committee for its next meeting. I think we just need the pace on that. Thank you for what you've been doing there. Can I take a question from Subo? Then I want to move towards summing up in terms of and just make sure the board are assured. Subo.
Thank you, Chair. Thank you, Emma, Scott and John. Really informative, as Lucy said, the presentation is really great to see, especially from my perspective, and having heard from some people really on the front line how difficult it is. So thank you for that. No, a lot of work is going in, and it was good to see some information there on staff wellbeing, particularly around mental health, and also how the workforce is being managed. And just looking a little bit at some of the things that you said around the workforce. So you mentioned that the EMAs, you're still meeting some targets in some of the services, but they're moving out of those roles into other organisations as furlough times now coming to an end, and these staff are now moving back into other organisations. We talked about staff abstractions, it's very high. And you've also got a clinical skill mix, and you said there are some challenges there. I was going to probe on that, but I guess it's about abstractions and vacancies and recruitment and things like that is contributing to that challenge. But you've got 14 different skill sets, I understand, 50 to 60 clinical staff, 31 GPs, so it sounds like you've got a good mix there as well. But your recruitment timeframes, you're saying 16 weeks, and there's a low vacancy uptake, even though you're getting applications from CFRs. So when I pull this together, and you're doing all the things that we can do locally, we're trying to mix skill mix from 999 and 111 and try and use that flexibly, which is really good. We're trying to look at how we can look and prioritise all of the work that's coming in. So this is all good things that we can do locally. So I guess my question is about, is there more that we can do and help that we can seek nationally around workforce? Because we're not alone in this. And whilst the immediate short term is about looking to get perhaps some help from the armed forces, this isn't going to go away, as Emma, you pointed out. You know, winter's coming up and things are going to continue to be stressful, and we want people to have proper breaks. So I wonder, is there any help that we need, or any more help that we can seek around workforce to try and alleviate some of these problems?
Suba, I think it's a really good question. I think the furlough impact of people going back to their original careers is having an impact in it. Will have an impact in EMAs and health advisors in 111. I think that we are still having really big and significant challenges within primary care of recruiting of paramedics. Every week there are multiple adverts out, and every week I more or less I get emails from people who are looking to go, if not part-time, but all hearing about people going because they're being actively recruited. So I think there's some real, when you talk about national, I think it's local, regional and national, about how we increase the pipeline in. That's always one of the challenges, how when the overall demand for clinical staff, and as much as we talk about paramedics, when we're recruiting mental health practitioners, when we're recruiting nurses, it is a limited pool that we are all fishing from, and an ever increasing need. We've had conversations about, we've got nurses in 111 and ESC, which is great that there's a question. We're one of the few ambulance services that doesn't have nurses in a frontline function. And whether that be a DCA or a car or whatever, still TBC. But I think the national piece, for me, has to be recognising the scale of what is required, because also people are leaving the NHS. They're not even moving into other areas of health. They're leaving the NHS. So I think it has to be all of that. I do have to say, I think the fact that all the things that was in the press this week about the 3% pay rise, I think when people look at it and think, what's in it for me? There's job stability in a way that people have recognised never in a way before, because of the furlough position, and people in the NHS worked all the way through. But I think it has to be national workforce considerations of how we create stability, so we don't all end up trying to rob Peter to pay Paul, because we're in a shared position. And I think it's a real risk with almost getting into a market bidding situation if we're not careful. We're very careful. I think ambulance services are pretty good at working, in a collaborative way. But when adverts go out for greater pay and maybe less unsocial environments and work hours, it becomes very attractive for some of our staff to look at alternatives, and that's really difficult.
Thank you. I think that's one of the points which we need to pick up in the summary, Emma, because clearly there are future workforce challenges as well. Thank you. Terry, I see your hand raised here. Have you re-established contact?
Well, I think so. We'll see how long it lasts.
We're seeing you loud and clear in Crawley. Yeah.
Okay. So firstly, just to echo what I have heard, and that is that I thought the presentations were absolutely superb. And Lucy's point about how we can do stuff now we couldn't have done even a short while ago is very well made. I was interested particularly in the role that the commissioners are playing, bearing in mind that we're moving into ICSs. So I've heard there's lots of system working. We're not seeing it getting any better, though, are we? We're still not meeting any targets. I'm just wondering whether commissioners are, not only in bringing people together, but also helping us to understand that although we may have had between a 50 and 100% increase at some times the day in, for example, the calls 111 might expect, how are the commissioners supporting us as we take those issues forward?
Philip, do you want to come in with that one first of all?
I think on the 111, are you talking 111 primarily?
I'm just following up on both the presentations. So if you look at the presentation Emma did, what was very clear is I'm very reassured of the amount of work that's underway. What I'm not assured about is it's having any impact on our ability to meet our targets. And that's not a reflection on the work that's underway. It just is a reflection of how complex the system is at the moment. And the people who are meant to be sitting in the middle of that spider web are the commissioners historically. So you've spoken about, for example, the direct links into the HALO meetings. But it feels to me across all of our contractual agreements that we're failing to meet the contracted for targets. We are working very hard, but still not meeting them. And so I'm wondering what role the commissioners are playing in really helping us feel that what we're doing are the right things, and that they are doing all that we believe they should be doing to support both us and the system.
Okay. So on the 9 side, this is done through Barry Hartman's ICF. and they act as our commissioners. They are in many ways a conduit to the region, and so they are trying to get whatever help they can. But if I'm really honest, there's not a lot they can do at the moment. In 111, it's a bit more hands-on. So John spends a lot of time with the commissioners in 111, and you can be a bit more active with your support. But we're still trying to get central funding into the commissioners to pay for 111. 111 first, that started nearly a year ago. We heard about 2 months worth of funding, which was the 23 million that Phil was talking about. That is only for 2 months, and then we'll be back to the begging bowl. But that's particularly the role of the commissioners in 111.
But I think, Terry, what I think I'm hearing you say, though, it's an important point, is that in spite of our best efforts, and our efforts are significant, so no one is criticising what we're doing. In fact, we're praising what the efforts our workforce are making, our leadership and the workforce. I mean, we can't ask any more of them. But what's clear is we're at this kind of seismic shift point where those that commission our services and that demand profile needs to be rebased. And we do need to get into a different conversation with the ICSs, because clearly we're at that point where we're just about holding it together, and thanks to the professionalism of our staff, we're just about hanging on and keeping people safe. But this is not sustainable. Hopefully if COVID goes away in the next 6 months, maybe that might have some impact. But what we're also seeing is, what I'm hearing is the profile of demand is changing, particularly demand on 111. And we do need to get longer term, being more strategic. We've got to do things differently in the future with our commissioners.
David, thank you.
What you're saying?
Thank you. Yeah. So I think what I'm saying is that I've been hugely impressed with the actions in place to address the commitments that we have made in terms of our commission services, but we are still not meeting our commission targets. I'm not an exec. I'm not a professional in the way that Emma is, for example. But I genuinely, you could sit me down and beat me about the head with a wet kipper, and I still couldn't come up with anything else that I think our guys could be doing. So it's of huge credit to our staff, the additional work they are doing, not just in terms of the guys on the road meeting the calls where the pressures are enormous, but also every single person who supports them in getting to that call. It's hard to know how they could do more. So it's really important as we move forward that there is an understanding across the system of not only those pressures, but of the work that is going on. The difficulty we have, and I heard John mention this a few times, it's the so what question that actually I think we've become used to over the years, measuring the impact of what we do. And it must be terribly disheartening for many of our colleagues who are moving heaven and earth to change the metrics, but are seeing no impact. And I presume that's because what's stacking up behind is just a tsunami of demand. So I think it's also important that us as a board are also extraordinarily supportive of our executive colleagues, because this is one of those few occasions where I'm looking at what's being done, seeing a very limited impact, but genuinely not understanding and not knowing what more could be done. So I think it's a huge credit to colleagues, both on the exec and those who report into them. But it really does highlight the fact that we are facing an unprecedented surge in demand for our services, for which we are neither funded nor actually equipped.
Thank you. That's a really good point, and I'll bring that into the summary. I think one final question from Howard, then we must move on. But I think we've probably got to the nub of this morning around performance. Howard?
So just to follow on that point, it is, and I think it's summarised in somewhere in the IPR, where, quote, "we do not have enough resources to meet demand," close quote. And I think that is the essence of it. You know, what we're all saying, we're doing everything we possibly can, but we do not have the resources to meet the demand that is there. And so the discussion, as I think implied by yourself, David, is around, or sorry, and Terry, is around the discussion with the commissioners to say this is what we're doing. We're doing everything we possibly can, and we're still not meeting the targets. And can we then have a discussion around, what else there is you would want us to do, or have a wider discussion around funding and the ARP targets.
Okay, thank you, Howard. Let's quickly summarise this, and then we must move on. But I think it's been important we had this discussion. What we, as a board, we received a very detailed presentation this morning from the executive colleagues, for which we thank you warmly for the detail which you've gone into. And we can see from that, and as Terry and my colleagues have said on the board, that there's clearly every effort is being made through 999 and 111 to manage demand. We're all concerned regarding the increase in incidents and in complaints. At the same time, we are assured that every effort is being made by the clinical teams in the trust, and we've heard good evidence today in the discussions that we have mobilised clinicians not only to see patients but also to intervene in the calls, to assess, to audit, to really look at the detail of that interaction with the clinicians. But as has been implied, in spite of that effort, it may not be enough given the profile of demand currently. But I think as a board, we can be assured, and we thank warmly both the executive but also the workforce for the extreme efforts they're making. The cautionary point is it can't go on like this. You can't go on like this, because we've not only got people working excessive hours, carrying excessive demand, we have a workforce that, even in spite of their holidays, is having high levels of sickness, and we are now seeing some leakage into other parts of the service, or people not beginning to cope well because of the pressures. So I think in terms of, whilst we're assured currently, and we're assured that we've got eyes on the strategic solutions, what I think as a board we've really got to focus on are the challenges around workforce going forward. So in terms of strategic work, the workforce challenges remain significant, not only to supply our current pipeline, but also ensure that we're motivating our staff, keeping them well managed, but also looking at different that nature of workforce. And I know that work is in hand, but we've really got to make sure that's in the eye line of all that we're doing. And I think the final point, the big point as well, is that it can't go on like this. And part of it, we're not blaming the commissioners. We're saying is we've now got to a point where there has to be a paradigm shift, a shift in thinking here, because currently the NHS is strained in all parts. The good point is we're working together better than I can remember for the last 20 years since the formation of the internal market. So that's a plus point. Relationships are good, thanks to what the executive have done. We're on speaking terms with everybody. We've really got to make sure now we bring that home to Advantage. And in our planning for the next contract round and others, we really do need to set out our stall there. And that's going to be key work for you, Philip, I think, as Chief Executive, to lead that, particularly with our new Director of Strategy, is to make sure that case is cogently made, is well written, and is objective. And he's not seen us as being emotional, but we're doing it based on fact, because this can't carry on and our patients will suffer. Is that a fair summary of where we think we are, board? Is there anything else we think we should be doing at this stage? Because important, because we're being watched by this. This is important from the point of view of our work as a board. Are we assured that we're doing all we can to keep our patients safe at this point? So Terry, final comment?
Just one question. I wonder if we, because our 999 and 111 services we know are not all encompassing across the area. I'm just wondering what data we have about the performance of 111 in Surrey, so that we can lay that alongside our performance, so that we can be assured that we are performing in line with the 111 services in Surrey. I'm conscious that because we are a public body, all of our material is public. Because the services run in Surrey are run by Care UK under their new operating model, I'm not sure if we have the same access to data. But I think it'd be helpful for the board to see the 111 data for Surrey, so we can get a picture of what the performance is across the whole of the CCAM operating patch.
Okay. Can I just check, John, do you see that information?
We see it only, so Terry's right.
It's commercially sensitive.
It's commercial. We don't get sight of the data the way we used to, of course. What we do is get the national sit reps, which you have to sort of knife and fork your way through it, but it is possible to do that. What I would, and I'm happy to do it, potentially. I think we tried to do a bit of that in this presentation, where we've tried to do that contextualization with our neighbours where possible. I think the bit that is important to note is that they have a very different operating model. So theirs is an out of hours face-to-face base appointments built into their model as well, which is I suppose the knobs and whistles and bells version of a fully integrated model, as opposed to our CAS, which is fully operational. So it's a bit like comparing apples and pears. That said, there is merit to certainly some of the metrics around the referral outcomes, which I think are useful to as a point of reference and call answering data. So that's something we could do, definitely.
If I may, John, well, thank you. It's a really important point. You raised, Terry. What I would suggest is that, Philip, particularly in our dealings with our lead commissioner, I think the bottom line is we're trying to provide a regional response here. Our ambulances are not necessarily county specific. We go across county boundaries. We go to different addresses, and you can, Philip, our ambulances are travelling more miles now than they've ever done, trying to give the public a decent service. So we're trying to provide a regional service. So we need a regional response to the people we deal with. So there needs to be visibility. So I think that's an important point in our commissioning conversations, that we have that to make sure the public can be assured we're using every bit of public resource to the best effect. So I think that is an important point. Okay, I do want to move on, but I think it's important we're dealing with that given the current issues. So colleagues, can we move on to the most of which the performance report, many of which we've covered in this previous discussion. But Philip, you're going to lead us through this. Performance we've largely discussed, haven't we? I would have thought.
So I don't think we should spend any time doing the operations piece. Emma, is there anything that you wanted to pick up?
No, I think we've covered everything, Philip.
I think we've had an exhaustive discussion on that, appropriate discussion.
So we
the finance report. Howard, if you could introduce the finance committee report.
Yeah, thanks, John. We've completed the first quarter reporting. Board will be aware we've got a half-year plan of 5 million deficit. Just to reiterate, the reason we have a planned deficit is predominantly because of the interim funding arrangements that have been put in place in response to the pandemic, which have disadvantaged us somewhat. So it's nothing to do with loss of grip on our cost base, just to reassure the board on that. We've been sort of forced into short-term planning horizon, so it's very unusual to obviously set a plan for only half a year, and it's very unusual at this point not to know what our funding is going to be in the second half of the year. So significant uncertainty around that, and that uncertainty will continue at least until September, when the planning guidance is going to be issued. In terms of the performance, we delivered our first quarter deficit 3.1 million. Pay was slightly under plan, non-pay slightly over. The two offset each other. Our cash position at the end of Q1 is 35.9 million, which was 8.4 million above plan. That's mainly down to timing rather than anything else. Our capital plan for the year is 25.5 million, so we've got quite a significant capital program going. Includes two make-ready builds, Medway and Banstead, and we're receiving 9.4 million from what's called Wave 4 funding from the centre for the Medway development. So that leaves sort of around 16 million that we're self-funding in terms of the capital programme. And interesting, if you compare that number 16.1, and it's not that unusual a year in terms of the level of capital investment against the 36 million of cash, it does sort of make you realise that while the cash balance looks sort of reasonably comfortable in the short term, longer term it's going to be under pressure and that I think emphasises the importance that we start to deliver cash surpluses in future in order to ensure the security of our capital plan without having to apply for sort of loans, etc. The main risk, I think, has already been highlighted. It's in the board assurance framework. It's the uncertainty I've just mentioned. That applies both to the 999 and 111 funding for the second half and beyond. Obviously, John O'Sullivan mentioned that we've and I think Philip referenced that some funding has been announced for 111 first, but it's a bit of a drip feed because all it covers, in fact, is sort of 2 months into the second half of the year, and we still don't have confirmation that full funding will be provided for the pressure that is 111 first.
That's the 4.3 million you're talking about, is it?
It's the 2.3 has been announced nationally, and it's our share of that, which I think is to be determined.
What about the 4.3 that's subject to further discussion?
Yeah, we're sort of escalating this issue through commissioners. I think commissioners' hands are sort of tied somewhat because there's national decisions that are required in terms of applying the funding. Our contract for 111 is 18.4, and our estimate of the impact of 111 first increases that by 6.8 million. So we do have a reasonable level of assurance around the first half year. So roughly 3.4 has been confirmed. What we don't have is apart from our share of the 2.3, what amount is going to be funded in the second half of the year. So
4.3, how it is for 999. Not 111.
Right. Okay. Yeah. Thank you. Thanks.
Thank you.
Sorry, just one other point, Chair, if I may. The NHS England have issued a new single oversight assurance framework, which includes financial metrics. The board would be aware of the use of resources rating that was previously used to assess sort of financial risk. That's changing, so there's a more simplified set of metrics that looks more at trends rather than sort of just purely sort of a snapshot of performance. So I think that's a positive move, and we'll be incorporating that into the integrated performance report in future. Happy to take any questions.
Thank you. So Philip, in summary, we're meeting our financial duties, but there's plenty of risk going forward.
Indeed.
Okay. Howard, for your financial report, please.
Yep. So just very briefly, because we've covered an awful lot of it already. So the first two sections dealt with operational performance, which we've covered. The third point deals with the Make Ready and Strategic Estates update, where we were provided with information on that. We noted parking was an issue at Medway, and I understand a draft of a traffic plan now exists and is being reviewed. So we'll receive that later on. We had a useful update on commissioning contracts and the joint commissioning forum, which David Hammond set up, and it's probably quite a useful forum to cover some of the issues we've raised today. The budget update, basically Philip Astell has just gone through. It's encouraging to see the COVID costs continue to be supported and funded specifically, but we're aware of the funding shortfalls as we are at the moment. Even though we're broadly on target at the moment, we're still looking at a significant shortfall, 5 million for the half year and roughly 10 million for the full year, unless anything changes. Yeah, there's an OS point on outstanding point on the PAP private ambulance activity, which we raised, and I notice there's still an issue in the current page on page 33. So the question was, our actual costs of private ambulance providers still remain at roughly 50% of plan. So at the moment, what this is telling us, rightly or wrongly, and it must be something wrong somewhere, unless is that the level of private ambulance we're actually using is 50% of plan, and yet we're obviously wanting to go above plan, and we understand that they're unable to go above plan, but this is telling us we're 50% below plan, which just sounds wrong in the current circumstance. Similarly, on agency costs, we are behind plan, which again does not sit comfortably with the concept of where we're at. Actually seeing an underspend on agency and PAPs. But that's an I'm not necessarily looking for an answer now, but that's an outstanding point that needs follow-up. On financial planning, yes, Philip's just covered that. Capital programme, we were assured, so that's okay, which Philip's also just covered. And then we just had an update on the electronic patient prescribing, which was a great success, which we acknowledged. A fantastic work was done on that. And then finally, we were looking at patient transport services and the executive continuing to look at the opportunities there. But let's watch this space on that. That's it. Thanks.
Thank you, Howard. Philip, do you want to come back on the points regarding private ambulance provision?
Yeah, thanks, Chair. Yeah, I had that checked out, and in fact, we've allocated too much of the COVID budget. We've allocated too much to PAPs, and it should have been allocated in other areas. So it's not that we're not delivering the level of PAPs that we intended to deliver. So there's a realignment of the budget that's required there. On the agency, I mean, I think generally, I mean, we are constrained on the use of agency, and the NHS England is driving initiatives to reduce the use of agency. And it mainly relates to non-patient facing areas as well. So I would say that a reduction in agency is generally a good thing. Rather than
I would agree with normal circumstances, absolutely, and support that as a principle. But we're not in normal circumstances, and if we've got patient care issues, then the use of agency staff would be justified, in my view. So that would be just a comment. Yeah.
Well, I'm sure the executive will note that there's always that trade-off between cost and quality with agency, but nevertheless, I think I'll ask the executive to note that comment. Thank you. If there's no other outstanding questions on the financial reports, can we move on to quality and patient safety? Then I think Fiona, then Bethan will highlight by exception. Fiona.
Thank you, Chair. So I thought it might be useful just to talk a little bit about patient safety, because we've heard a lot from Emma and from Scott around the challenges that we've had in providing a timely response to some of our patients and how the Trust has responded to that. So normally we rely quite heavily on our staff highlighting incidents when they go to patients where there's been a delayed response. We look at complaints and that sort of thing. But with the continuing levels of demand, we felt there was a need to undertake regular reviews into those patients who had a delayed response. And Bethan's team have done an amazing job in undertaking harm reviews, initially on all the double breaches for C2s and all the triple breaches for any category of call. And over the last 6 weeks, we've undertaken a total of 2,212 harm reviews. And of those, over 2,000, so 2,035 showed no harm when we investigated the call. There was low harm in around 102 cases, moderate harm in 51, and high harm in 3. So all the moderate and high harms are further looked at the serious incident group. to see what, when we've got all the information, including the patient outcome, whether there is evidence that we did not keep that patient safe and they came to harm whilst in our care. And that has led to an increase in the number of serious incidents that we've recorded. We are theming these so we have so that we can undertake cluster reviews, because that is actually much more effective in establishing the learning than investigating each case individually. So we're looking at those cases where there's been a delay to C1s, and that's a very small group. But we have found a change in the pattern of serious incidents. So you'll be aware that we've had significant delays over the past year in going to C3 calls where there's been a delayed response. But over the last 6 weeks, we've seen a number of C2 cases. So ST elevation, myocardial infarction, strokes, so patients with potentially life-threatening conditions where the patient has evidence of harm. So that is a cluster, a C2 cluster. We've also identified some areas which are historically difficult to reach, or where we often see delayed responses. So, for example, Edenbridge is a difficult area to reach, and Polegate and Hastings has had some quite poor response times over the past 6 weeks. So again, another cluster, in addition to the other SIs, which are not related to patient delays, which we will always see, but are of small numbers. So in terms of what we are doing to address these issues, we're flagging with EOC the increase in the C2 SIs, so that the clinicians in EOC are looking actively at the C2s as they come in, because all C2s are not equal, and you can flag the most seriously unwell C2s to make sure that they get a response. They're also looking at the C2s which are going out of time to see if there are any patients in that group which who require being upgraded or having a P1 priority put on them, so the next resource is sent. Emma and Scott have already talked about maximising clinical input, both on the road but into the control rooms as well, both in terms of case reviews and in undertaking welfare calls for patients where we have not yet managed to send a response. We've seen an increased use of our paramedic practitioners. So there's a pilot that's been undertaken at Ashford. This is really very small numbers as yet, but using video conferencing to deal with patients with a delayed response. And Emma's and Scott have also talked about the new Pathways Clinical Review, the PACS. I can never remember when I'm asked what it stands for, but the PACS system, and an increasing number of clinicians are undertaking training on that. That's not a quick fix, because it's a day's training followed by 2 4-hour mentoring shifts for each of those individuals, but it is something we are rolling out as quickly as possible. Then I mentioned earlier the system involvement that we've undertaken with regular updates for our system partners, and the cooperation we've had from NHS England on the local patch to address this with in terms of hospital handover delays, diverts and interfacility transfers, and also actions to try and reduce the number of patients that GPs are referring by ambulance to hospital. So I think that addresses patient safety. Thank you, Chair.
Thank you, Fiona. Very comprehensive. Any questions from the board on Fiona has said? I think we can take comfort from I think one, to encourage the staff to keep reporting serious incidents, and I think that's encouraging. We need to, but if we don't want to see them or hear about them, we want to make sure though they are reported and investigated appropriately, and I would encourage our staff to do that. Thank you for that. Bethan?
Thank you, Chair. Fiona's done an amazing expert job there of outlining patient safety elements. I just had 2 quick things specific to the IPR. I just wanted, so one is a typo, but a really important typo. Don't know if anybody's picked it up, but in the violence and aggression data, so instances of violence and aggression against staff, in the narrative exception report around it, it states that we had 773 cases rather than 73. So that's a really, really important thing to note, because we don't want, clearly 73 is still 73 too many, but it absolutely is not 773. So I just wanted to clarify that, and we'll make sure we amend the report. And then just the second thing for me is an update on the risk position. So we've talked at board many times around how difficult it is to get staff to go and review their risks. So we're actually, as a trust, really good at getting people to put risks onto a risk register. We're really good at talking about them at committees. We're just not very good at going back into the system and putting an update on around this. And part of the reason for that is that we haven't had a centralised resource for risk for a few months now. But I'm pleased to say we have made a permanent appointment to that post. And they will be starting with us shortly. So hopefully, I mean, that won't fix it magically. It's still around changing the culture and behaviours of staff as well, but it will massively help that issue. So I just thought it'd be useful to provide that update. And that was all from me. Thanks, Chair.
Thank you. Any questions from colleagues? We've heard from the executive there about what we're doing to keep our patients safe. So Lucy?
I did have one on violence and aggression. I did assume that was a typo, but there is an uptick in the amount of violence and aggression. In Philip's report, he mentioned the body-worn cameras, but we were undertaking a programme of measures. I was wondering if you could update the board on what those are.
Yeah, Emma, do you want to give the update on the body-worn cameras?
Yes, of course, thank you. So the body-worn cameras have gone live. They are in place at the 5 trial sites that we agreed. When I went to Brighton last, saw them in action, beginning to get people using them. I think it's going to be a little bit of slow burn, people getting used to them, but they are out there and they are in use from that point of view. And the project team is monitoring their use and linking with the national team that's collating all the data from across ambulance services. So that's probably the piece around the body-worn cameras. I know part of the project was also considering other options that we could do to do a compare and contrast, particularly around some understanding how to de-escalate scenarios, and we're still working through the options relating to that. The body-worn cameras is a year-long pilot that we're participating in.
So we are undertaking other actions than just the body-worn cameras.
That was the plan, and what we have been clear with in our pilot, our part of it, is that we wanted, because this is about a long-term offer, this is about what actually will provide the best, what is the best way for us to support our staff to be able to manage escalating situations, and the body-worn cameras may be part of it, but they may not be all part of it, and we need to think about the broader range of managing those difficult circumstances.
Thank you.
Thank you. Chris, then Peter.
Thank you very much, Fiona, for your report. I was really quite impressed that you are doing these regular reviews of the C2s. And what I just wanted to know is how many of those C2s get escalated to PIs, and how effective is that?
PI being?
So I can't give you the data of how many of the C2s get escalated. We review all C2 double breaches. So those are all patients that we don't respond to in twice the ARP standard. But the P1 on the CAD of the prioritising particular cases is a dynamic thing. So if you've got a stack of, say, 12 P1s on the stack, you might put a P1 on one of them, but then review of the stack again might indicate that there was a patient that was of a higher potential priority. So that's a dynamic thing. So I'm not able to give you that information. But the double breach harm reviews are undertaken for all C2s, although what we're finding is that it's a huge amount of work and it's involving the entire SI team so that they're not able to do their day job of undertaking SI investigations and getting the learning from those. So going forward, we will reduce that to 50% of the double breaches and 10% of the triple breaches. So that will make it hopefully more manageable, because at the moment it's a massive piece of work. And I don't feel that from the cases that we're taking to the SI group that we're actually learning any more from the other 50%.
That's very helpful. Thank you very much, Fiona.
Thank you. Just need to keep an eye on the time now, Peter.
Yes, sorry, Chairman, just very quickly, just in response to Lucy's question about the steps being taken under violence and aggression to staff. In the WWC report in the pack, there's a reference to the work that committee is doing in this regard. I think it's fair to say that there's some outstanding assurance that it's seeking and plans to follow that up at its next meeting.
Thank you, Peter. Clarifying. Can we move on there? Tom, you present your QPS report.
Thanks, David. So a lot of this has been covered and indeed updated in the discussions we've been having at this morning's meeting. But we focused on management of serious incidents and keeping patients safe in REAP 4 as the key issues at the last meeting, and we had a really good discussion about incident reporting, and we recognised as a committee that the impact of investigating these incidents is having on the staff who are investigating them and dealing with them, and the potential there for distress and moral injury, because of course we are seeing, as Fiona's alluded to, incidents occurring to some of our patients that no one wants that to happen. So we recognise the sensitivity around that. We were assured that the executive have this in hand, that we're seeing good incident reporting, and the related harm reviews are of high quality. We also recognise, though, and thought the board should be aware, that because of, and Fiona's mentioned this, because of the amount of work that's needed on this, and also the need sometimes to involve patient-facing staff in some of these reviews, that this is taking a bit longer than it normally would. The patient safety in REAP 4 has been covered in depth today, so I won't necessarily go through that, except I will raise the point that we were told that when in sustained surge, as we are, consideration should be given to advising appropriate patients to make their own way to hospital. And I know Philip mentioned that a bit in his report. Sorry about that. We had another paper on bariatric care. Now, bariatric care is a relatively low volume activity for the Trust, with an average of 37 incidents a month requiring the bariatric service. We were encouraged to note the high number of safeguarding incidents is reported, which suggests that staff are really aware of some of the issues facing patients, and these are very vulnerable patients, of course. We identified a number of actions, including a review of the policies to make sure that they reflect what's needed in the current state, and training, particularly of the OTLs, who are the go-to people when bariatric services are required. We've asked for a management response on that in due course. We had a paper on the medicines management review, very helpful, but we did ask for a response again with a more action focused. So there is apparently an action plan for medicines management following that review, but we didn't see it at committee, so we've asked for that to come back so that we can see what actions are proposed and the timescale for them. There was an issue about resourcing a replacement for the Omnicell, and that's going to be quite a significant financial investment, and clearly no decisions have been made about that, and that'll go to a future committee. We had an important and very, very well written paper on the review of clinical services and outcomes by a clinical grade. And this was important because it highlighted some gaps in assurance and concerns about whether non-registered staff or our newly qualified paramedic staff are consistently operating within their scope of practice. And so we've asked Fiona and team to come back to us with more information on that when it's available. And so we're going to have a paper in September. And then we received the clinical audit annual report, which was a very high quality report. But again, we felt as a committee it would be useful to have a bit more information on the response to areas that were identified as needing improvement and action plans for them. We'll receive that updated report at our next meeting. Thank you.
Thank you, Tom. I'm not seeing any hands raised, so unless there are any other questions, move speedily on to just thank you for the report. If I move on to workforce and well-being, Ali, any issues you want to highlight by exception?
Yeah, just briefly, Chairman, conscious of the fact that there's been a lot of discussion about the workforce issues already this morning in terms of the stress on the service and the absence levels and things. So I won't go over those things again because that's been extensively covered. Two other things to cover, I think, just briefly. In the IPR, there's a single page on the impact, I think, which we can see on statutory mandatory training because of the fact that we've been prioritising getting hours on the road effectively. So I think that's I guess that's not a surprise really. That's lower than we would normally expect it to be at this time of year. So I think just to flag that, and I think that there is a clear reason for that as well. The other thing I think just to say, which just to pick up, because this hasn't been covered in any of the workforce bits so far, is that in terms of our recruitment for this year, we're actually doing fairly well in terms of like newly qualified paramedics. And as at this time last year, we've made a similar number of offers actually to last year, but we've actually over offered this year in terms of new starters because last year what we saw was about 20 to 30 drifted off to other trusts, as people do. That they look at a range of offers, get an offer in for a number of different trusts, and then choose the one they want to near at the time, which we can leave you high and dry, a bit like the graduate recruitment market, really, in general. So we currently offered 182 offers against a target of 166, and the July and August intakes are looking good, and the rest of the year is looking good if we can continue in that vein as well. So in terms of sort of are we keeping the pipeline going as well, which is the lifeblood of our service really, that's actually going fairly well at the moment. So fingers crossed it will stay like that as well. So I wanted to comment on that particularly because we hadn't spoken on recruitment at all today, but we have covered a lot of the other areas. So
thank you, Ali. That last point you made goes back to the point that Lucy made earlier regarding where we were last year, year before, in terms of our performance as an organisation. So that's encouraging to hear that we've managed to get that coordination right and the flow right. So thank you for that. I think the board would. I think I'd have to say the board obviously know we're concerned around statutory mandatory training. We understand that. I think everyone understands the position around the boardroom table. But I think there's another reason, again, in our narrative going forward and in contract discussions and others, we're meeting demands at the expense of not helping our staff as much as we should in terms of their statutory mandatory. Well, we have to do this anyway, but it's important for our staff to keep them safe and to keep them up to date with the latest. So that certainly is a risk we need to manage carefully going forward and be aware of as a board, that we're meeting demands, but there's a price to meeting that demand. And that's the board have been concerned about it in the past, and one I think we need to keep the workforce committee really on the ball with and actively encourage to try and make good that backlog. Given I know Laurie's not available today, but the workforce report is on the table. I'm not proposing we go through it. Are there any, given the time pressures, but not wishing to diminish its importance, is there anything from the workforce report the board wish to question? Because there are other members of the workforce committee here at the meeting. So you're happy to receive that? There's no other. I think most big areas have been covered. Can we move on to the audit, risk and charitable funds committee? Michael?
Yeah, very quickly, Chair, in the interest of time. I have nothing formally to report from the audit committee. This is the first committee of the next business cycle, and so our workload, what we consider, was not as onerous as it has been in other committee meetings. I would give overall board assurance as to where we are in terms of the operations of CEDA. There were issues that is probably just worth briefly highlighting. One was around risk, and I think Peter has alluded to that. There are areas of risk that we would like to consider a little bit more detail, and particularly we think the time is probably right for the board to look at risk in its entirety at a separate session, and I think that will be organised over the next few months. We also had a discussion around the project that Emma referred to, which is looking in the longer term, how do we improve the operating model that's touching on a whole range of issues around structure, workforce planning, workforce deployment, the development of a performance cell. This is a major project, and it impacts in terms of scrutiny. It falls in the remit of all the committees: workforce, finance and investment, audit and patient quality. And we think that this is worthwhile bringing to a separate session of the board, just to look at how it all interacts in terms of governance. It is also part of the internal audit programme. There is a specific assignment for their internal audit to look at the overall governance of that programme, which will take place. So those are the two issues. On charitable funds, a very good meeting, grateful to colleagues. We were incredibly impressed by the way in which monies raised have been utilised to support the well-being of CCAM people. But there were a number of issues that we did, which I think is worthwhile bringing to the board's attention. First is, given the level of activity now and the level of funds that that CCAM has available to it from charitable sources, we endorsed the proposal by management to recruit a part-time professional employee to actually manage our charitable funds activities and to support fundraising generally. And we asked that that person be in place by December of this current calendar year. We also supported, once this person is in place, that the time is right to revisit the strategy around how we use charitable funds and how we go about raising charitable funds on behalf of CCAM. So that was particularly important. We also were mindful of a point that has been made to us by the community first responder group within CCAM and volunteers more generally, the length of time it takes for projects that are proposed to be funded through charitable funds, how long they take to go through the system. While we fully recognise that there needs to be appropriate due diligence and there needs to be a recognition that value for money is being delivered, we do think it would be worthwhile having an indicator that would show on average how long does it take for a typical project to be approved. And we asked the executive to go away and consider that. And then the final, probably more substantial item, which I'm grateful for Howard pursuing, is that we have around 200,000 reserves of funds that have not yet been utilised on behalf of CCAM people and the communities that we serve. We need to be careful on this. We need to make sure that the money is spent appropriately. But given the challenges that we face and the importance of supporting CCAM people, we want to look a little bit more detail as to whether the use of that money could be accelerated. And Howard and I will be meeting with David Hammond when he returns from leave to look at that in a little bit more detail. Those are my items, Chair.
It's very rare that a board utters the words "spend some more money." But in the point of the charitable funds, that's what the charitable funds committee is encouraging. Really, we've got the money. The public have been very kind, and we need to do our best to go and get some more when people are offering the goodwill that our staff have. And there's little wonder, given what we've heard today, the goodwill our staff have. We need to make sure we capitalise on that. It's all part of a win-win solution in the long term. So thank you for that, Howard. I don't see any hand raised. Thank you for the report. We're now got an important matter of amendment to our constitution, being a foundation trust that sets us apart from the others. So foundation, we have to amend our constitution, Peter.
Yeah, thanks, Chairman. So hopefully the paper is relatively self-explanatory. I'll just confirm, just spend a minute or two just confirming what we're asking here. So there are two amendments being proposed. The first is to provide a shorter term of office for some governors elected at the next elections in early 2022, next year. And the reason for this is to better align the timing of the elections. And specifically, this is to remove the potential that currently exists for, during any 1 year, a change in the governors of up to 2/3, which, you know, naturally creates instability and so on. So the proposed change limits this risk to a maximum of 1/3. And in the paper, it sets out how we need to change the constitution to make that provision. And the second change, also in the paper, is to simply add one additional governor position to the Lower West constituency in 2022 to ensure equal representation, and that's based on population numbers for both Lower East and Lower West. So something we've been thinking about for a while, and we're just using the opportunity of making this change to ensure this change is also added. And just to confirm that both changes have been approved by the Council of Governors, and of course any change to the constitution requires both the approval of governors and the board.
Thank you, Peter. So board, are you happy to support that change to our constitution? Okay, passed unanimously. Thank you. We now come to the close of the meeting. Time is pressing, but we are reporting a public meeting. I'm conscious we do have some people public on the call. Can I ask, are there any urgent questions relating to the business of today's meeting that can't be handled in a written question afterwards? So anything that people feel should be brought to the attention of the whole board in their question, particularly relating to the quality of our service and the work we're doing to keep the public safe and support our staff. Typical opportunities. I don't see any hands. I think someone's just dropped the microphone rather than raising their hand, so we can then bring the meeting to a close if we may. Are we clear, Peter, on the actions we need to take from the public part of the meeting?
Yeah, I think so.
Yeah, no urgent business?
No.
Thank you. And in meeting effectiveness, well, I'm for once, I'm not going to apologise on overrunning, because I think it's a really important. The presentations were appropriately lengthy anyway, so we lost some discussion time, and I wasn't going to lose that, given the importance of where we are in our service to the public. So, any other comments, please make them to me. Send me a note or comment in other ways. We'll now close the meeting, and we'll reconvene. I think meal break policy is important, even for board directors. So, can I suggest that we reconvene at 2:15, please? We can be through the business quite speedily at part 2, I think, but I think we need a short break. So we'll meet again for part 2 at 2:15. So thank you all for your efforts.